Well, welcome everybody. We'll have more to join us to the Biomechanics Summit 23. Here we are. It finally came. I'm really looking forward to a crackerjack lineup. Our first speaker is going to be Chuck Lingham. He's out of Strathshire University and has done a lot of biomechanics research with the World Health Organization. Before we get to his talk, though, I've got a couple people that I want to just mention thanking for the help and also helping with some sponsorship. First, Rita Yates. Rita isn't signed in yet, but thank you, Rita, for helping to get this out to Academy membership. We have a meeting coming up with the American Academy of Podiatric Sports Medicine, and a lot of people that are here are members. And Mike Donato is going to tell us when that is momentarily. And the one sponsor that we have is a speaker, Brian Kentner. He's going to be talking with his company, the 3D Printed Foot, later in the program. And then with the advent of different sorts of compression sleeves and braces over the last decade, I've had the pleasure of working with Dave Higgins. Our relationship started with a SOC article that I wrote with Podiatry Management. And Doug Ritchie had done a lot of diabetic SOC research, and they collaborated, and we were able to get some things on sizing and venting and for diabetics, and we reviewed some of that info. And now in more recent times, Dave has pioneered getting wicking fabrics with compression splints, and this is just a prototype of something we did called turf toe splint, the TT3, and this is something we developed a couple years ago, but he has something he's going to touch on as we get people admitted here with a plantar fascia compression sleeve system that's kind of a package. And welcome, Dave, and tell us a little bit about this this nice little kit that you have for plantar fasciitis, one of the more common things that we see.
Well, thank you, Ben, and thanks to everyone for the opportunity to just say a few words. And I wish you a very successful conference here. So OS First is our company and our brand. And about 13 years ago, we created the idea of using compression therapy in products.
Did your mom put you to work?
Orthopedic benefits.
Okay.
Kenya, can you please just mute your?
Are you going to get paid?
Kenya, can you please mute your?
Do you need a paycheck?
Let me
You
just
hear that, Mom?
Oh,
She needs a paycheck.
okay, sorry about that, Dave. Dave, let's take it from the top. I'm sorry, I'll just cut that
That's
out.
all right. We all pay taxes. No problem. Again, my name is Dave Higgins, and I'm the creator of a company called OS First. And we design and manufacture compression therapy garments, but we're focused on orthopedic outcomes as opposed to just vascular outcomes. And we've grown this technology we call compression zone technology for some time, and it's quite a large and successful endeavor at this point. And Dr. Pearl has been a critical partner for us in our designs and functional developments of products. And he mentioned the turf toe product a little bit earlier. So what I'm just showing you here is a more recent development where we have a series of products designed for various levels of plantar fasciitis treatment and prevention. And so this just gives you an example of what compression zone technology is about. This is a product that mimics the kind of taping that many of you might do or learn to do for early stages of plantar fasciitis. This is an ongoing compression foot sleeve to help take away the pain and to improve the pressure relief of the natural fat pads through compression. And then we have performance sock products that we've developed with targeted compressions that are designed specifically to help prevention and ongoing care of plantar fasciitis. And we take this approach with almost all orthopedic conditions from the foot, ankle, all the way out to the wrists. And we've had great success with that. These are all focused Class 1 FDA products that are focused on palliative care, prevention, and pain relief. And as a result of that, we've had a great deal of success with this idea. I'd be happy to make contact with anyone that's here. You'll see the video. You can contact me, and I'll be happy to explain further and get you samples or information that you might be interested in.
And folks,
Thanks a lot, Dan.
anybody that's interested can also contact me as well. And I can tell you they do a nice job of giving you intro samples, just like we did with this is the prototype of the turf toe splint. The one thing that Josh, your son, had mentioned is that FS6, which I had used at night for patients, the DH3 that you have has a little less toggle pressure in the Achilles, and it's going to be, so it makes for less burning, for some people that have a little pressure point there. And that's the key is knowing the right grade of medical compression. And Natch, I know that we're going to bring you on in a moment, but one of the things that isn't necessarily in the meat of your discussion, but maybe you can just mention as a sideways glancing, is how pressure management with proprioception with things like compression sleeves also influences things within the foot and footwear. So that's something you have enough of a background where I'm sure you'll be able to freelance off your main slide presentation. So without further ado, let me introduce our first speaker, Nachpan Choklingham. He's a professor, and he's going to be talking to us about pressure management in footwear and in the foot. Please go ahead and get started with your program. We're looking forward to it.
Okay. Good evening, and thank you for the introduction, Ben. I hope you could see my screen.
Yes.
Okay. Good evening, and thanks for joining us. The topic of footwear and foot biomechanics is very vast, and I could discuss this for hours and days. However, I only have 30 minutes this evening, and so I'm trying to focus on providing a general overview of the field and setting the stage for other speakers. I think you've got a fantastic lineup for us. So some of the things that Ben just mentioned, probably we'll touch on it during after the presentation, probably with one or two of your questions. But for now, I've decided to focus on the broad understanding of the field rather than presenting results from specific studies. So in that context, that's the title of the talk. I'll try and keep it as general as possible, as I said, rather than trying to cover into specific results from any of our studies. What can you expect in the next 10-15 minutes? I'll provide you with an overview of the technologies to measure foot and footwear biomechanics, as well as some of the techniques and the data collected in research studies. I'll also touch on some specific experiments and the relevance to the field, and discuss the translational nature of our research using our own examples. To start the lecture off, I'll provide some basic information on foot and footwear biomechanics, including some structures and functions of the foot, probably impact of different types of shoes on the foot. And I'll also mention some common measurement techniques such as gait analysis and pressure mapping. I'll delve into the current state of the art, including the recent studies and advances in technology. Finally, I'll discuss some of the potential areas for future research and development with a focus on foot and footwear biomechanics, including new technologies, experimental methods, and applications for the field. I'm I'm quite used to running over time. So I think, Ben, if you could keep time, I usually keep talking. So if you could let me know how I'm doing for
I
time,
got
that'd
you
be great.
covered.
And as I said, we could elaborate on some of those topics after the talk. So to set the scene then, foot versus footwear biomechanics. Probably I'm talking to the converted here, but still I'll try and touch on my thought process. Foot biomechanics refers to the study of the mechanical functioning of the foot, including the bones, muscles, joints, tendons, ligaments, and all that. It examines how the foot moves and supports the body during activities such as walking, running, or jumping, or any physical activities. Footwear biomechanics, on the other hand, refers to how the study of shoes or footwear affect the mechanical functioning of the foot. That's how I define to some of my students. These include the type of shoes, the high heels or athletic shoes, for example, and how they influence the way that the foot moves and supports the body. And it also examines, the footwear biomechanics also examines how the shoe design and the materials can impact foot health and injury risk. And I'll give you some specific examples in the coming slides. So before we proceed, essentially, foot biomechanics focuses on the natural functioning of the foot and understanding the dynamics, while footwear biomechanics focuses on the impact of shoes on the foot. Both of them are very close to my heart. Both of them are important in understanding how best to support and protect this marvelous machine, as one of the philosophers said during our physical activity, walking or running. So understanding the difference between foot and footwear biomechanics is very important for several reasons. And that's the reason I'm kind of emphasizing this. The first couple of things, it's about foot health. By understanding the mechanical functioning of the foot, we can better understand how to support and protect it during the physical activity. And the knowledge of the foot biomechanics can help us prevent foot injuries and the overall foot health. On the other hand, footwear biomechanics, the shoe selection, understanding how different types of shoes affect the foot can help individuals to make more informed decisions while selecting shoes for different activities. And this is a key area for us in terms of pediatric shoes and the influence of footwear choice in the life course of girls and women, and we have got a particular program of work around that topic, and if time permits, I'll expand on that. The third thing that I want to highlight is the performance enhancement. This is where pressure and load measurement comes in as an important element. By understanding how shoes can impact foot mechanics, and by measuring load and pressure, we can design shoes that optimize the performance for athletes or for certain activities. It includes, when I say performance enhancement, I kind of loosely include foot orthotics into it too. Talking about foot orthotics, that's where the next link comes in, which is the injury prevention. So it's not just about the treatment of injuries, it's also about preventing injuries. And if you all as clinicians, when you assess these people who come into your clinics, understanding how shoes affect the foot can help prevent injuries caused by inappropriate footwear. So footwear protects, at the same time, it also creates trouble. So, and that's what links to Ben said about my work with the WHO. Most of my work within the WHO relates back to assistive technology and rehabilitation. So knowledge of foot and footwear biomechanics is extremely important and can be used to design rehabilitation programs, protocols, and appropriate clinical management for individuals with foot and ankle conditions. Last but not least, people like me who are lab rats. I'm very proud to call myself a lab rat in that sense. We spent a lot of time in the lab understanding the mechanics of the foot and how shoes impact it. Either it is casual footwear, everyday footwear, or running shoes. So all of that is extremely important. And that's the reason why I had a specific slide on this to highlight the difference between foot and footwear biomechanics. It's not interchangeable. They're distinctively different, and one needs to understand the differences. Now, the next setting the scene for me to give you the basics is the foot kinematics and kinetics. Both of them, some of you have heard me speak in this forum and other forums. Both kinematics and kinetics are important aspects of foot biomechanics. But the topic for this evening is about kinetics. So on the left, I've got various marker sets and about kinematics. Foot kinematics refers to the study, the movement of the foot, including its position, orientation, movement of joints, and in various physical activities. It typically provides you with a range of motion and the motion patterns of foot. Last time when I spoke here, I think I talked about coordination variability. So that's not the topic for this evening. In terms of foot kinetics, the study of forces or moments acting on the foot during movement is extremely important. This includes forces generated by the muscles, the forces transmitted through the bones and joints, and of course, the force exerted by the ground, what we call ground reaction force. So, although both kinematics and kinetics are important in understanding foot function and movement pattern, the kinetics is considered to be more important in our case because it provides specific information about the forces acting on the joint, which affects foot stability, balance, the ability to generate power, but also, more importantly, it can be related to the risk of injury. So, foot kinetics, such as the measurement of pressure, distribution, and muscle activity, can help all of us, researchers and practitioners, not only to design shoes, orthotics, but also can help support and protect the foot from any type of injuries. Now, in the context of foot and footwear biomechanics and kinetics, measuring force and pressure are kind of related, but they're distinct. Force refers to the amount of push or pull exerted on the object. In foot biomechanics context, force measurements are used to determine the amount of force exerted by the muscle, tendons, ligaments of the foot during various activities. It can also refer to the forces transmitted to bones and joints. And as I just said, it's also related to the ground reaction force. Pressure, on the other hand, refers to the force exerted over a specific unit area, surface per unit area. So in foot biomechanics, pressure measurements are typically used to measure or assess the distribution of forces across the foot. And this information helps us to understand how the foot is loaded and to identify the areas that may be the risk of injury, that may be at the risk of injury. So both force measurements and pressure measurements are important. Force plates is one of the technologies, and they measure the ground reaction force during activities, any type of activities. They typically consist of a flat surface, as you could see upon the screen, and the sensors measure the force exerted on the plate. They can provide information about the vertical, the medial lateral, or the anterior posterior forces or components of the ground reaction force. And they do help understand the mechanics of the foot and the impact of different types of shoes on the foot. On the other hand, on the middle there is the in-shoe pressure measurement systems. These kind of systems consist of sensors embedded in the sole or the insole of the shoe to measure the pressure exerted on different types of the foot, different parts of the foot, I should say. So in that sense, they can provide distribution of pressure across the foot and how it changes with different types of shoes or different types of foot conditions or pathologies. We also have pressure plate systems, pedobarography, as some people call it. It's a similar kind of pressure measurement, but it uses a pressure plate rather than an issue pressure system. Now, it's not just about the technology. I'm using this particular paper that you see up on screen as an example of how a structured methodology for data collection and reporting can be used to gain a deeper understanding, if you want to say it, of the characteristics of orthotic materials and how they affect gait. When we published this study, the main aim of the study was to improve the clinical decision-making process, or this program of work. The main aim was to improve the clinical decision-making process when it comes to orthotic materials. The results, when you download the paper, you got the full reference there, showed that the medium density polyurethane may have different loading characteristics, which could make it suitable for patients with compromised ability to deal with pressure. So this was the first ever paper to have some quantifiable information on PU footbeds for patients with diabetes. The reason why I'm highlighting this paper is I want to emphasize the importance of using structured methodology for data collection and reporting, and stress the importance of understanding how it's being measured in order to make informed decision. So on the left-hand side of the screen, you could see how we have split the foot into various regions. And if you see, most of our papers using plantar pressure measurement would have used similar type of technology. Similar type of technique, I should say, not technology. So whatever technologies we use to make the data comparable, we tend to use these type of masks in some systems, or areas in some system, regions in some regions of interest. So it's important that we use appropriate techniques to measure force or pressure. So in studying foot and footwear biomechanics, it's also on focusing on load or pressure. It's important to consider the center of pressure trajectory, which is typically not reported in many papers or many of the software, for example, but it can provide very valuable information. The central pressure trajectory, which depends on the type of software interface used in whatever system you use, gives an idea of the time in addition to the pressure distribution. So it has both temporal parameters and also in terms of the pressure distribution. So there are several papers that deal with this and discuss its useful clinical management and the footwear advice. However, the main thing that I'm trying to get at is that using different type of variables available for you in terms of pressure measurement or load measurement can add to your clinical decision-making process or the way that you design your devices. On the right-hand side, I've quoted another paper from us, which is more recent than the other paper on the left. It's again to highlight the usefulness of pressure time integral. So many of us tend to stick to peak pressure or average pressure. So it's all about what I'm trying to emphasize is variables like center pressure progression. The pressure time integral is extremely important. The pressure time integral measures that particular measure combines the time and loading, and it's clinically very relevant. So for example, one of our studies found that people with diabetes and neuropathy who tend to load their feet more heavily also tend to have plantar soft tissues with lower hardness. So this difference in tissue hardness is likely to affect the tissue's vulnerability to avoid overuse injury. That's what we have quoted in that paper. So the reason why I'm relating that back here is it's important that people just not just think about the pathologies. It's about quite a bit about measuring pressure and the usefulness of pressure and using appropriate variables. Now, measuring the load under the foot, as I've outlined in the last 15 minutes or so, is important in understanding footwear biomechanics. And the point that I'm trying to make within this slide is, in terms of in-shoe pressure measurement, there are various techniques, there are various technologies. Over the years, the earliest forms of in-shoe pressure measurement were systems based on thin film transducers, which were placed under the insole of the foot, insole of the shoe, to measure pressure. The systems have been around since the 1970s and 80s. And they were primarily used in research settings. But over the years, with the advances in technology, and there are various commercial vendors, and I'm one of those guys who use all of those systems. That I've got various systems in our lab we tend to use. And I've used one particular set of technology there on the screen. And what I'm trying to get at is, over the years, the advances in technology have led to the development of more sophisticated and advanced mat systems and also in-shoe pressure systems. The state-of-the-art in-shoe pressure measurement systems are small, lightweight, highly accurate, durable, and they can measure pressure in real time, and they can send the data remotely. And you've got systems like F-scan by TechScan or PIDA by Novell. All of these systems provide some of those variables I talked about in terms of peak pressure, pressure time integral, and also the center of pressure. And also in the middle, you have the mat-based systems such as the MatScan from TechScan, the TechScan Walkway, as some of you would know it, or the Gate-Ride system. So one of the things that I wanted to highlight within this slide is about the number of sensors. And I normally, when I do lectures, people do ask me about the number of sensors in the in-shoe pressure measurement system or the mat system. Definitely, the number of sensors in in-shoe pressure measurement system is an important factor, because it determines the level of detail and the accuracy of data that can be obtained from these systems. The systems, of course, with more sensors would provide more detailed and accurate picture of the pressure distribution under the foot, as it can measure pressure in more areas or much more detail. The system with fewer sensors will provide less detailed, less accurate picture of the pressure distribution. But the point that I want to make on the right-hand side is the F-scan 64 system. The reason why I'm mentioning this is the number of sensors in an in-shoe system also affects the resolution of the data. A system with more sensors have a higher resolution. That means it might be able to detect the changes in the pressure distribution. It's important for identifying subtle changes in pressure distribution that may be associated with certain foot conditions or injuries. So it's the optimum number of sensors. It's not that you need a large number of sensors or you can cope with one sensor. It depends on what you want to measure, how you want to measure it, and what your main purpose is. And in that sense, systems like this F-scan 64 might be enough for your use, and that's the clinical and that's the technical judgment that you need to make depending on what your needs are. And on the other hand, the advancements in technology, talking about advancements in technology, it's definitely allowed for more detailed understanding of foot biomechanics over the years. So in my earlier days as a researcher, force plate targeting, as we call it those days, was a major difficulty in gait analysis. So we tend to have people walk across our lab, and we won't tell them where the force plate is, but then we'll be there for days in the lab, and they won't be hitting the force plate. But now we've got technologies like instrumented treadmills, which opens up a lot of doors in terms of load measurement and force measurement, and which enables us with a wide range of experiments. And recently, how are we doing for time, Ben? We're okay?
We're good. I want to give you, we're at 5:01, about 5:05. We can have enough time to ask questions and.
Okay. I'll quickly run through. Recently, some of our research is focused on the loading characteristics of the soft tissues on the plantar soft tissues with individuals with diabetes. The reason why I'm looking at it is I'm trying to introduce a couple of new technologies that we use, and which relates back to loading characteristics and also the pressure distribution. We've been examining how these tissues are affected by increased load and pressure that can occur as a result of the disease or as a result of diabetes. This overall program of work aims to better understand the potential mechanisms that contribute to the development of diabetic foot complications and ultimately inform design of more effective interventions for preventing and managing these complications. Another area of work which I have not given you up there is our research group is currently exploring the use of shear wave elastography to use soft tissues in foot, to understand soft tissues in the foot, particularly the individuals with diabetes. Shear wave elastography is a technique that uses ultrasound waves to measure elasticity or stiffness of the tissue. By assessing the elastic properties of the plantar soft tissues in individuals with diabetes, we hope to gain a better understanding of how these tissues are affected by this disease and the potential targets for interventions to reduce the risk of ulcers. So one of the main variables for us is the stuff that Ben just mentioned, is about plantar pressures and also about measurement of shear. And we'll come back to shear measurement in a bit. So quickly going to the next set of papers. Again, I'm pretty certain I can provide you with a copy of this presentation so that you have listed those papers. That's not an issue. And it is about relating, again, all of these research that I'm providing you on screen has a clear focus, and main variables that we are measuring relates back to load and pressure. And what we have shown is measuring the stiffness, measuring the loading characteristics using plantar pressure. And if you use appropriate technology and appropriate techniques, we can achieve all of your clinical management outcomes you want to achieve. On the left-hand side is a 3D printed insole development that we've done, which has been the latest work is currently being written up for publication. It's pending publication on a huge clinical trial using that approach. Now, the more appropriate and more for a bedside orthotic clinics here in the UK, again, use of plantar pressures and plantar pressure measurement, how can it help you in terms of simple clinical interventions and providing an evidence base for your own work? Again, I've given you a couple of examples of what we've done in terms of using pressure measurements in getting to provide evidence for your clinical approaches. Here is another set. How does pressure measurement relates back to footwear? I mentioned about footwear choice and the life course of the influence of footwear choice in the life course of females. Again, you've got a good set of papers there which would show you that teenage girls, how their footwear choice and the clear relationship to the footwear choices made by young women and the potential impact on foot health on the right-hand side when we measured the footwear choice and the plantar pressure aspects and the impact of fit in older women who come into normal podiatric clinics. Again, you've got a whole program of work which showcases how important plantar pressure measurement is and our load assessment is in terms not only for your clinical intervention, but also for your footwear advice and also the choice of orthotics that you would give. And the other end of the spectrum is about current program of work on how to choose footwear and the footwear choice, and also tools that we are developing in terms of managing children. And here is an exciting program of work. There are more papers to come in. I couldn't stop myself from sharing this information with you. I'm just going to skip that. I wanted to talk to you within this slide. It's about the impact of footwear upper on the footwear sole. And this is where measuring the pressure distribution in the dorsum of the foot is equally important as measuring pressure in the sole of the foot. Probably we can touch on that during some of those question answer sessions. Equally, it's about the material selection of footwear, both for the upper and also for the sole of the foot. Again, the material selection is important and it influences the shear forces or the plantar pressure aspects of your interventions and your approach. Here is the latest in terms of pressure measurement. We've been working on an insole prescription concept. So the idea that people who are interested in can go and read this paper. The idea is we have got a 3D printed device, which you can give it to your patient. The patient takes it, uses it for 3-4 days a week, whatever they do. And it essentially is an automatic prescription for an orthotic intervention. So that's what we have tried with that approach. So the way forward, to finish off, the way forward, the message from me is combine new technologies and new techniques. There's so many are there. It's about use of appropriate technologies and techniques. But using these technologies and techniques, we can definitely understand this marvelous machine. And we still have a long way to go. And I wanted to kind of give you a feel for the importance of measuring pressure or force under the foot. I think I'm going to stop there, Ben.
Wonderful presentation, Natch. And I'm going to lead off the first question, which relates to pressure as it relates to compression. Ben Onig, of course, has talked about the oscillations that occur within the soft tissue compartments, those eccentric movements that sometimes cause the tissue irritation, whether it be shin splints or plantar fasciitis. You know, one of the interesting things that Dave at OS First did is they took one of these sleeves, and it's kind of an ankle sleeve called the FS6. They put it around the heel, and they found that the fat pad came in a little bit more underfoot, like it took some of the lateral margins of the fat pad if you're looking from behind and brought it under. But above and beyond that, what would be the body of knowledge that we need to investigate to understand more the proprioceptive and kinesthetic things that some of these compression devices are doing? Because obviously we have people that subjectively say, yeah, you know, that takes the edge off. You know, they'll have, just like in first aid, you know, we splint something, we put a wrap around it. What do you see as some of the ways that we can more specifically measure something that isn't underfoot per se, but around the foot, trying to manage a soft tissue compartment.
I'm not too sure if I understood your question fully, but I'll try and answer it. And if I don't,
Or just
please
any
come back.
general comments you have on, because there's been a lot of fad science on, do you get performance or athletic injury improvements with compression therapy? Those, and we know, of course, with blood flow and so forth, that has been proven, with venous insufficiency, but above and beyond that, trying to help with inflammation and tendonitis and things of that nature, ankle sprains, etc.
Yeah, in essence, it's multifactorial, isn't it? You mentioned blood circulation, and we have a program of work to look at the microcirculation aspects, the thermal aspects, and how it affects relates back to pressure. So I fully agree, and that's the reason why I said in the last couple of slides about measuring pressure in the dorsum of the foot is equally important as the pressure under the foot. Because when we have footwear, and we know for sure, and I think I presented, some of you might have seen the data that I presented, when you have a tighter fitting shoe, you've got a medial shift of the center of pressure. Obviously, that shows that it's going to create trouble in the whole kinetic change. So in that sense, when you have devices like compression socks, and it definitely influences the pressure and the function of the foot. And the other thing that people might have heard me speak about is the articulating surfaces within the joints of the foot joints, and we fully don't understand how our pressure distribution and how tight-fitting shoes or loose-fitting shoes affect that.
Does anyone else have any other questions for Natch before he gets on with his rest of his evening?
I do.
Yes, sir.
Good evening, sir. I'm Lloyd Muller, and I'm a longtime professional ski instructor. Ben knows my background, and I'm wondering if your work has been spread to the ski boot industry. This is what you're describing here is critically important, because the forces that create pressures are enormous. Skiers pull turns at 80 miles an hour, and their feet must be able to respond effectively and continue the maneuvers, the turns, and so on. Otherwise, the skier is very liable to wind up seriously injured because they lose their track. I can tell you from long personal experience that my feet are pretty warped from living in this environment. So do you have any comments here, sir?
Thanks for that comment, Lloyd. The short answer is we have done some pressure measurement in dry ski slopes in the UK in the earlier days. In terms of our novel interventions and some of the stuff that I was talking about, plantar soft tissue stiffness and all that, we have not done anything recently related to ski boots or skis. Definitely that will be an area of interest for us, and I'd be more than happy to speak to you.
I do want to share with you, both of you, and Lloyd knows Tom Gelly through another mutual ski instructor, guy that we taught with, that there is a carve system that one of my FitFoot guests, Tom Gelly, who's a professional demo ski instructor, has used, and they use that.
And he's also a physical therapist.
That is true. And he has used that feedback to coach virtually his students. So I would encourage cross-pollination there with the ski industry. And it's nice when we can not all be in our vertical silos, so that, like your World Health Organization information can be shared with APMA and ski industry, et cetera. Anybody else have any other questions before I get Dr. Simon Bartold, our next speaker?
Yeah, Ben, this is Ted Forkham. I have one quick
Ted?
question is, I just want to see if what kind of studies have turned out between some of the force pressures on the plantar surface of the foot with different width shoes, because you've had the trends of going towards, say, wider footwear towards standard footwear. So I just want to see if there's any comment on that.
There have been some studies, particularly with a focus on kind of orthotic interventions within P&O industry rather than sports. We ourselves have done some work on shoes made with various types of lasts, which we haven't published, but I think I did present in a conference a few years ago with out-flare lasts and in-flare lasts, and we used a specific company to make the similar design shoes with varying lasts, and the lasts had different widths. I think that's what you're asking about. We do have some data. We have not published it. There is quite a lot of difference, and that's important in the sense that what we tried to get at within that piece of work was patient-specific intervention or individual-specific intervention and how it differs. And we used plantar pressures and the resultant ground reaction forces as an outcome measure. Does that answer your question?
That was a great answer. Yeah, and I'll let Ted speak for himself. Ted, you're back.
Yeah, no, thank you very much. And so since it's not published, I'm not going to press you more on the outcome study results on that.
And I know that tightness of shoes is a topic that's very near to a couple of our colleagues' hearts. I know Golden, Harper, and Ray are big on that. And Ray has pointed out a circulation study that a lot of shoes, we just size them a little too tight in general because that's what we're accustomed to. Well, without further ado, and thank you so much. I want to keep on track. Thank you, Natch. You're welcome to time out if you need to, or catch some of Simon's talk. Simon Bartold is our next speaker. He really needs no introduction. He's got his Bartold Clinical. He's worked with ASICS, he's worked with Solomon, and he's going to be talking to us today on the mechanics of growth anomalies. Simon, are you out there?
I'm right here. Thanks,
here
Ben.
you are.
Can you hear me okay?
Okay, there you are, like magic. Welcome.
Thank you very much. Should we get underway?
Sure.
Okay, I'll just share my screen.
It's a little choppy. Hopefully we got a steady signal. Let's go. There we go.
Well, first of all, I'd like to say thanks to you, Ben, for
Are you able to dial in a sweet spot, Simon? I can see your screen fine.
It's a nightmare to put this together with people in different time zones, and I just noticed that my friend Nachi is still going and looking splendid at 10:15 evening in. Yep. What do you want me to do, Ben?
Oh, no, I was just going to say, hopefully you find the sweet spot. It was a little pingy on maybe your Wi-Fi reception, but let's keep going forward and see if it smooths out.
What do you want me to do, Ben?
Oh, you're good. Proceed, please.
Can you hear me, Ben?
I can. Yes.
Okay, no worries. So you've given me the task of talking about the biomechanics of injuries in children today, and I thought we might paint a slightly broader picture here and just have, and some of this will be a bit of revision, but also I think there will be some information here that is new and perhaps surprising to many of you. Let's get stuck into this and see what we come up with. So when we look at the growing athlete, obviously we've got very specific physiological differences to adults, and we're going to go through some of these in detail. But I think when we look at this, we just want to take a backward step here and look at what's precipitating some of these issues. So if we have a look at the data here of children who play sport, about 75% of all healthy children between 8. In the USA, about 50% of boys and 25% of girls aged 8 to 16 play sport, so that number drops a bit. But if we have a look at this number here, about half of US young people aged 12 to 21 are not playing sport regularly, so they're not active regularly. 25% engage in no vigorous activity, and about 14% do absolutely nothing. I mean, nothing. They play no sport, they have no physical activity, whatever, at even a light to moderate level of activity. Now, girls are at greater risk of inactivity than boys for a number of different reasons, particularly during and after puberty, and there are a number of psychological reasons for this, body image, etc. But this is creating what is officially now been defined by the Centers for Disease Control as a global childhood obesity crisis. And this is very typical of what we see, that kids trying to be active, but they're fighting a rearguard battle here because the damage has already been done quite early on in their life. We've now got 124 million obese children worldwide. I'll just let that number sink in for a moment because it's a very large number. And that number was 1% in 1975. Now, 5.6% of girls and 7.8% of boys, from the latest data from a few years ago, are considered obese. So almost 8% of all children would be considered obese. 10% of children in the US, in the UK are estimated to be obese, and these numbers would be reflective around the globe. So it's not that much different in Australia. It certainly would be similar in the USA. So should we worry about this? Well, if we have a look at these numbers and you look at the prevalence rate of overweight and obesity by class in boys and girls aged from 0 to 19, you can see that this is something we do need to worry about, classified as overweight or obese in the USA in the year 2016. This is a pretty scary number, right? So this is really where the point I'm trying to make here is that sport is perhaps the solution to this problem, or physical activity is perhaps the solution to this problem. It's just so important that we encourage kids to play sport for a number of different reasons. If we have a look at this in the USA, in the 5 to 17-year-old age group, about 4.3 million sports and recreational injuries occur annually. And these are defined as injuries that actually present to an ER or to a doctor's office. So that is the definition of an injury. And about 1.9 million of these are classified as serious injuries in the USA. The male to female ratio of injuries is almost 2 to 1, which is not surprising. And we'll talk about that, why that might be in a little bit. And this is data that's reasonably recent from Comstock and co-workers. So what are the issues for kids who play sport? Well, I think we can probably divide this into 3 main buckets. So we've got physiological issues, we've got psychological issues, and we've got chronological issues. And these all combine this sort of sweet spot in the middle here, the intersecting spot here, to create a potential for an issue. And that's what we're going to talk about. So first of all, let's have a look at some of the psychological issues. Well, one of the most important ones is the ugly parent syndrome, and this is parents who are wanting to live vicariously through their children's sporting prowess, and they go beyond the boundaries of what we would consider to be acceptable in encouraging their children to play sport. In other words, they just push them into an area where they are simply overloading the musculoskeletal system to a point where it can't cope. So that's one of the most important. Sheer pressure of competition is very important. So down here in Australia, you know, we have this crazy game called Australian rules football, which is a complete misnomer because there are no rules. But basically, we have kids down here quite often who are playing sport for their school. They're playing club sport. If they're good enough, they'll be playing representative sport, and they are playing an enormous amount of sport. Some of these kids, especially in the vulnerable ages of 9 to say 16 are literally playing more sport than professional athletes because of this combination of school versus club versus representative playing. And so we have to ask the question, and as healthcare practitioners, we have to be in control of how much is too much for these athletes. How much can their system take? What's the load titration for these kids? And it's very important. Decision making is also really, really important psychological factor of children's injury. And by that, I mean, this is really about risk taking, and it's especially important for boys. Boys, we know, do tend to take more risks than girls. So it might be a tackle, it might be play, it might be the way they train. And this is one of the reasons that at the moment, the injury rate in boys is almost 2 to 1. But it is changing. So we're seeing an evening up of that between boys and girls, quite possibly because now with the introduction of girls into higher contact sports like Australian rules football, like rugby. I'm sure there are American football leagues for girls now. They're getting involved in full contact sports. And so the risk injury ratios are changing as we move on. One of the things that, sorry, just go back here. One of the things that we often forget is this slide at the bottom left-hand corner here. And that is that the preeminent reason for kids to play sport is to be a bit crazy and to have fun. And if we lose sight of that, then that's a huge pity, because that is the most important feature of children's sport. We really need to make it fun and make them enjoy it, because if they don't, they'll drop out of sport, and then we see all these associated issues here. All right, so having a look at some of the chronological issues here, which we don't often talk about very much, but one of the issues here is that children often compete against each other according to age and not size. I think this is one of the biggest problems. And I can fully remember playing Aussie rules football when I was about 14, and I was a small kid. And I can remember playing against guys who would be on the field, pretty much a full beard, magnificent moustaches. You know, it's just super intimidating for a small kid to be playing against physically mature kids. And so we've got to try to understand how we might action this. And this is more about getting back to grassroots rules of the sport. But you can see here in lacrosse, obviously a huge chronological difference here. And I'd put it to you that maybe we should be encouraging children's sport bracketing according to physiological age rather than chronological age, because chronological age just doesn't work. If we have a look at this top slide here, this is a young guy who's a star junior player in New Zealand. He will no doubt end up being an All Black at some point in time. And he's absolutely huge. And he's playing against these smaller kids. And you can see here, this tackle is a particularly dangerous tackle for anybody really, but for a child with a very large boy tackling quite a small boy, there is a huge potential for a serious, if not catastrophic injury here. And then again, at the end of the day, you don't want to see your kid down on the ground, just obviously not enjoying what's going on. So I do think this is an issue. At the moment, across the board for sports, this definition of age participation is not very well defined at all in most sports. Certainly not here in Australia with Australian rules or rugby, two sports that have the potential for quite serious injury in children. All right, let's move on to the physiological side of things now. And this is really what we want to talk about, I guess. But we have to recognize these differences we have. So we've got, in children, huge differences in coordination. So some kids are much later in developing motor skills than other kids. Huge difference in tendon strength, in ligament strength, in bone strength, in skill levels, and in mental attitudes. And all of those pool to give us the potential for these injuries we see in children. There are, of course, very significant musculoskeletal differences between kids, adolescents, and adults. And as I said, some of this will be revision, but in amongst all this, I'm hoping to be able to drop a couple of pearls. Okay, and these differences define the injury patterns we see in kids. So what we see here is, we know that the strongest links are the ligaments, the tendons, and the muscles. And so this really defines the complete change in the injury profile we see between children and adults. So in adults, fractures are quite common, sprains are quite common, those sorts of things. In kids, we don't tend to see fractures unless it's very acute trauma. We see much different injuries in particular. Yeah, one of the most important things here is to understand the difference between the physis and the epiphysis, because the growth cartilage of the physis, which is adjacent to the apophysis or an epiphysis, is the weakest link in the chain. And that's why we see all of the osteochondroses that are occurring in kids, right from the hips all the way down, the most common injury in sport, and there are good physiological reasons for this. Now, the other thing that happens with kids is that their healing rates are different. So muscle and bone heal faster in children. They're a lot more elastic. So as a result, I think that true joint sprains, tendon ligament injuries, they're relatively rare. And things like the fasciopathies, like if you want to call it plantar fasciitis, I don't think these exist in kids, and that might be a controversial statement that people want to talk about later. But I don't believe in my career I've ever seen a case of true plantar fasciopathy or plantar heel pain in a child that wasn't an osteochondrosis. Now, there are some other pretty important considerations here as well. First of all, we have this situation where we get a very profound imbalance between strength and flexibility during this peak of linear growth. So some kids can grow a foot in a year, and that profoundly upsets the balance. It affects neuromotor control, it affects flexibility, it affects strength, but they're still playing sport at the same level, and they might still be being pushed, and so that creates a huge issue. So we do see this particular window of opportunity for injury in adolescence. So the peak is around this period of 13 to 16 is where we start to see a lot of these injuries really starting to grow. The other thing that's important to note here is that when you have these rapid periods of growth, we get structural changes to the growth center. It becomes thicker, it becomes more fragile, and therefore it becomes more vulnerable to injury. And when you have sudden overloads during injury, then you have potential for injury. A couple of other important considerations. When we have the prepubescent growth spurt, this is also associated with a transient deficit in bone mineralization. So we get a transient period of osteopenia. And this is really quite important. You should not be thinking that this is like adult osteoporosis or osteopenia. It's not. It's transient. It goes away. But it does, again, open this window of opportunity for injury. And it is quite important to consider this when you're looking at kids' injuries. Okay, just quickly running through a couple of these injuries and some relatively new information on this. So let's talk about avulsion injury. And these are the sorts of injuries we see. So you pull off a chunk of bone because the ligament is so strong. And we see them in all sorts of different areas, from things like the elbow, obviously here, to the knee. We've said this, that ligaments are stronger in bone, so we don't suffer tendon or ligament injury, but you suffer an avulsion injury, and some of these are quite important. Having a look at these two, obviously we've got a couple that as podiatrists we see very commonly. You can see that this is being caused by an ankle inversion injury. The ligaments are so strong that unfortunately the ligaments don't give way, but the bones do. And you can see this is a bit of a mess. So we've got a multitude of different injuries here, from the base of the fifth MT through to the medial malleolus. We've got a mid-shaft fracture of the fibula here. So these are the sorts of injuries that you can see with a severe inversion injury in a child. Now, let's talk about the osteochondroses, because these are the things that we're most likely to see clinically. And there is some very interesting information on this coming through right now. So these are, we should consider these a group of disorders. And they're different. The osteochondroses are different, slightly different to osteochondritis. And I want to make that point clear, that osteochondritis is a bit different. We okay, Ben? Can you still hear me okay?
Yeah.
Yep, okay, good. So osteochondritis, obviously, by its nomenclature, indicates it's an inflammatory process. Osteochondroses are more involved as a degenerative process, so they are subtly different, and we need to make that point. But they affect the epiphysis or the epiphyseal equivalent segments of the immature skeleton. Now, they're believed to be primarily the result of traumatic or vascular pathology, often in the setting of overuse. Now, one of the really interesting new bits of information here is looking at the transition of the vascularization of bone in this particularly vulnerable age bracket between 8 and, let's say, about 14. So what actually happens here is that the vascularization of bone in this younger age group occurs in the medullary canals of bone. In other words, on the cortical part of bone. And around about age 14, this vascular supply should shift to becoming intramedullary. Okay. What we think happens here with the osteochondroses is we think that for some reason there's a glitch in the signal that tells the body to switch to this new version of vascularization, and it doesn't happen. And we think this is one of the reasons that kids get these osteochondrosis injuries. And that fits in quite nicely with what we see, because one of the great conundrums of the osteochondroses is simply why some kids get them and some kids don't. So they could be similar body size, same gender, playing the same amount of sport. Some kids get plagued by it and other kids don't. And it may well be if this switch that tells you to change the vascularization of bone is not being switched on, and that's a very important player in the generation of these injuries. So that's something to think about. These injuries, we tell our patients all the time, don't we, that don't worry, these injuries are self-limiting. As soon as you reach skeletal maturity, they're going to go away, and there's no problem with this injury. Just basically sit it out and it'll all be fine. This is not necessarily the case, and I want to underline this with a couple of injuries, because the new data is telling us that this is probably not actually what goes on. They're site, age, and gender specific, and when you have a look at them, they can be anywhere from upper body right down to things like the head of the second metatarsal. But one of the important things to note here is that the vast majority of them are in the lower limb. So there's a lot down here. If we have a look at Osgood-Schlatter's disease, here's a very typical picture of Osgood-Schlatter's disease. You can see the difference between the two knees. We've got some hypertrophy of the tibial tuberosity here as a result of the traction nature of Osgood-Schlatter's disease in this individual. And that's a pretty typical physical finding of this disease. The diagnosis is clinical, so you don't need to irradiate these people. You don't need to do advanced investigation of these people. The age group, as we might quote it, is about 11 to 13 in girls, a bit later in boys, 12 to 15. It's often in sports with directional changes, so things like basketball, football, all codes of football. Those are the sports where we see this, characterized by very prominent and tender tibial tuberosity, where the patellar tendon is inserting into the tibia. You'd only X-ray this if you're unsure of the diagnosis or you suspect that there's a separate bony ossicle. But one of the most important features here, one of the most important things is you make the features fit, because we have all seen unusual things happen around knees that might mimic the features of something like Osgood-Schlatter's disease, but can be different and at times can be sinister. And we need to be very sure that we have made the correct diagnosis. So I'm very big on history taking, and I'm very big on making the diagnosis. If you do need X-ray, you can see here with the MRI T1 weighted and T2 weighted images, it shows very clearly. So we are getting some bone marrow edema here as a result of the traction. Nothing really new to see here. One of the things that I do want to point out here is that often, or not often, but in about 12% of all cases of anterior knee pain, it can be at the level of the hip, and in particular a slipped capital femoral epiphysis or leg cavus, named after 3 people who described it simultaneously. So these are very important conditions. They can present as anterior knee pain in adolescents and children. And this is my comment: make the features fit. Make sure that you're not missing something very important. If you miss either of these 2 conditions, the hip, then we have a very serious problem here. So always think outside the box. The management, pretty straightforward. Activity modification. So look at your tissue load management here. There's some evidence that local heat might help. Analgesia, of course. Quad, hamstring stretching and strengthening. Just this whole exercise prescription side of things is super important for the osteochondrosis. So we don't have time to go into that in detail, but looking at exercise prescription is very, very important for this particular condition. Use of minimalist footwear is quite interesting and maybe quite comprehensive for this, but the theory behind this is what we do understand about minimalist footwear is that it basically, if you go to a much lower drop shoe, it will take the it will reduce the external knee joint moments. It will increase the external ankle joint moments, so you need to manage that, but it will reduce the load at the knee. So it might be sensible to even think about that for in a very managed way for a period of time. And also, one of the most important things here is something that sometimes we don't do as well as we might, is education. So advice regarding the prognosis, tell them what they can expect. Now, I did allude to this earlier on that some cases do not get better. And one of the very interesting things about Osgood-Schlatter disease is that tradition and what we tell our patients is that it's going to resolve within 12 to 18 months for about 90% of cases without lasting implication. And I'm sure that many of you would be thinking, yes, that's what I tell my patients. Well, in fact, the most recent literature has the age bracket for Osgood-Schlatter disease at 8 to 42 years of age. So Osgood-Schlatter disease can be an enduring condition that goes long into adulthood, but simply isn't correctly diagnosed. So it doesn't necessarily go away. This dogma that when the growth plate closes and is going to cause the symptoms to dissipate, and we can see Osgood-Schlatter disease going on into adulthood, and it's often being diagnosed as patellofemoral pain or some other condition of the knee, but it is actually enduring Osgood-Schlatter disease. So that's something that we want to take on board. And that's something that we might also have a bit of a think about with the condition that I see most commonly in sport in kids, and that is calcaneal epiphysitis. I love to call it Seaver's disease, which is politically incorrect because I'm a student of history and I know it was described by J.W. Seaver in 1908. And so I'm going to continue to call it Seaver's disease, even if people don't like it. But of course, the more correct description is calcaneal epiphysitis. Now, this is an injury to obviously a very susceptible growth plate. So it's poorly positioned. It's the site of the insertion of the Achilles tendon. It's the site of great impact areas. It's very common in active 8 to 17-year-olds, or should we make that 8 to 40-year-olds? I'm not really quite sure. It's very common. The ratio is 3.7 to 1,000 athlete hours. There are a couple of very easy tests you can do to define this. The single leg heel raise test is about 100% sensitive. Squeeze test is about 97% sensitive. But let's have a look at some of the features of this. So one of the questions we have to ask is it a traction injury? So we've always been told that the Achilles tendon, when you grow rapidly, starts to increase traction on the calcaneal apophysis. And this is one of the things that cause the injury. But of course, we've also got the issue of impact. And it was very interesting to hear Nachi's presentation. One of the things that that certainly Scott Waring talks about in terms of plantar heel pain is the change in the energy dissipation ratio of the plantar heel pad. So how is the energy dissipated, and what happens when that pad becomes more or less stiff? Does that influence the underlying tissues? And the answer is probably yes, it does. So it may well be that we're actually dealing more with a compressive injury, or even more likely is that we're dealing with a combination of both. And one of the things that we do notice anecdotally, and I wish somebody would do this study, but one of the things we do notice anecdotally in Australian football is Australian football is traditionally played in football boots without any effective raise gradient at all. In other words, completely zero drop boot. It has no heel whatsoever. And so kids in this vulnerable age group are going from wearing a school shoe with a 3/4 inch height heel. They're going into a football boot with zero raise at all. And it seems that this is actually stressing the calcaneal apophysis and may well be a contributor. This is anecdotal, but one of the things we do clinically is we immediately put them in either a boot that has a meaningful midsole, or we put a heel raise in the shoe, and it dramatically affects the way they recover from this condition. So my personal view is that no kid should be playing Australian football in a shoe that is zero drop. It's just asking for trouble, basically. I know Golden Harper's coming on later on. He may have some opposing views to that, which would be interesting, but we certainly have pretty good anecdotal evidence to support that statement. So this is when we talk about the radiographic appearance. I mean, parents often freak out when they see this sort of X-ray, because they say, look, it's a fracture, but this is a perfectly normal radiographic appearance of the calcaneal apophysis in pain-free controls. How do you treat it? Well, activity modification. Look, you've got to look at load management. This is the key issue. I've already mentioned that we look at footwear in particular is super important, and we could spend hours on footwear for this. Heel raises do appear to be helpful. Cushioning appears to be helpful. Obviously, looking at balancing up the triceps surae and looking at strength ratios is also very important. Exercise prescription, specific exercise prescription focused for this condition is super important. And looking at, as I've said, this footwear modification is very, very important. And orthoses as necessary. We're kind of in a world now where orthoses are a bit going out of fashion a bit, but I personally think they're still super important. Whether it be an OTC device or a custom device, they still can be super important, and they are a proven effective treatment modality. So just finishing up here, look, we've all got a pretty big responsibility when we're dealing with children in sport, and that is we want to encourage kids to make a lifetime commitment to weight-bearing physical activity at an early age. This is particularly important for girls. I cannot emphasize this enough. Girls are at risk. They have a very limited opportunity to build the bone bank between the ages of about 8 and 16. And after that, women have a progressive loss of bone tissue for the rest of their lives. And so it is super important that they build this healthy bone structure very early on in life and commit to a lifetime of weight-bearing exercise, because it is the fundamental player in bone health. Also, I think engaging in a variety of different activities is quite important. So we've got some really interesting data now saying that if you specialize in sport early on as a child, you're far more likely to get injured. So this is the whole concept of trying to minimize repetitive cumulative load. And you can do that by, if your main focus is soccer, then please also play some basketball. Please go out and do some trail running, do some other things, because the body hates cumulative repetitive load. So spreading the load and mixing up the input signals is very, very important. It's also quite important in footwear that you mix up the footwear you wear when you're playing sport. Finishing up with just one red flag. This term I hate, growing pains for me is right up there with metatarsalgia as two of my most hated terms. The questions you have to ask. So growing pains to me is an attempt to normalize pain. And painters should never try to trivialize or minimize pain. You shouldn't catastrophize it, but you need to understand why the pain's occurring. So does the pain last more than 24 hours? Does the pain increase with activity or sport? Is the pain only in one arm or one leg? If the answer to any of these questions is yes, then you need to investigate it further, and you should not simply say, it's growing pains, don't worry about it, it will go away. And certainly the other important thing is it near a joint? Okay, I give a little push here for my course on the osteochondrosis of the foot and leg, which is available on Bartol Clinical. And I'd love to hear from you, get a follow from you on any of the social media channels we're involved in. Thanks again to Ben for pulling this together. I hope there was something there that made you think a little bit and that will help you. It's Friday here now, so I live in the future, but you guys are on Thursday, but hopefully tomorrow at work, maybe you'll see a kid who comes in with Osgood-Schlater's disease, or maybe you'll see an adult who comes in with knee pain and think, I wonder if that might be residual Osgood-Schlater's disease. So thanks very much, and back to you, Ben.
All right, that was awesome, Simon, and we look forward to having you later in the program and on the panel when we wrap up, hopefully not too late into the new day for you. Our next speaker, Richard Blake, he is just another big pillar, and he's got a couple pillars that are out. Let me see if we can get back to the screen where everybody can see me. Let me see if these are Richard's latest books. He's going to be talking to us, Dr. Richard Blake, on practical biomechanics of the lower extremity, and maybe just sort of an intro to his philosophy. And I'm going to let Richard jump in here. And thank you so much for joining us, Richard, tonight. Can we get your screen shared, Rich? Do you have the shared screen there? So, okay, there's. Let me just see. I'm gonna, Ted, is that your screen that needs to be moved? That's okay. Rich, okay, here we go.
There we go.
You got a nice start for us. Well, welcome. He's been doing this a heck of a long time. He's the inventor of course, the Blake inverted orthosis, but I'm going to let him sort of guide us through what he's going to talk about. There's so much to talk about with your books.
Oh, well, thank you so much, Ben. Can everybody hear me?
Yeah.
Okay. So yes, I started this adventure at writing for my class at the California School of Podiatry. And I'm trying to, in a 4-book series, write, basic principles, how to do a gait evaluation, how to examine, do our biomechanical exams and so forth. So I finished books 1 and 2. I've got book 1 up here on the shared screen. Just to go through some of the basic principles. For my students, it's like wonderful because they'll, 6 years after I teach them, they'll be out in practice, and they will have forgotten probably what the difference between forefoot varus and forefoot valgus is, so hopefully by going step by step, I'll give them a good foundation on what causes injuries. The basic principle of practical biomechanics, as the title of the book says, is basically that there's so many things that we can do. I practice in a multidisciplinary practice, and the podiatrists, well, the MDs, the physical therapists, our local chiropractors, our local Feldenkrais workers, orthopedic surgeons, everybody's treating the patient and trying to get them better. And I see good results from almost everyone. We could argue that some methods will be better. I think the thing that podiatry does better than most is try to find the causes of these injuries. What is the cause? Because if you can find the cause, one, and it's usually more than one cause. I think there's like 3 causes of almost every injury, but once you find the causes that you can do, then you can both speed up the rehabilitation of the patient, and you can then prevent them from getting that injury over and over and over again. I mean, once the child has grown, they'll go through their growth. They won't get growing pains anymore, but the severe pronation that they have, or the leg length discrepancy, which Ted and I are going to talk about in a little bit, these things are going to stay with them. And if the equinus that was never recognized, the pes cavus foot that's a supinator. So anything we can do to help the patient discover why they got the injury, and then reversing that, and really telling them this is something you're going to need to deal with, as you go forward. And now that I'm at the end of my career, I can, cherish the cards I'm getting from my patients that said, thank you for helping me run for 40 years. Thank you for letting me, hike or dance for the last 40 years. And that's the most gratifying thing that we can get. So basically what I'm sharing the screen on is the first book. It basically shows you we talk about general principles. Everybody in this Zoom meeting here has their own principles in practice, and things that maybe you don't even realize that you have, things that general rules that are general for your profession, and also general rules that are like stuck to your soul, that you never want to break. Like I don't want to give a cortisone injection near the Achilles tendon. A good general rule, right? Some people say, oh yeah, but if you do it ultrasound based and you just get it in the bursa next to the Achilles tendon, you're fine. And like it breaks my golden rule. I won't do it. So there's basically things that you will develop or have developed that are tried and true for you, that you don't want to break. And if somebody else breaks them, that's okay. But so basically that's one thing. My book is not about orthotics, and Steve Privet was very kind when he reviewed the first book, saying, this is sort of, I'm not talking about root theory. I'm not talking about tissue stress theory. The sagittal plane facilitation theory. It's basically about changing, stresses. I guess it's closer to tissue stress, but it uses anything that I've developed as a practitioner. I love root biomechanics. I love over-the-counter orthotics that I can customize. I love training techniques. Just anything we can do, shoe gear, anything we can do to change the stresses. I always tell my runners, if you didn't run 5 miles an hour, if you ran 10 miles an hour, you probably wouldn't hurt. And of course they look at me, and I'm trying to get the point across, like, hey, you're overstriding. And there's so many ways that we can deal with these injuries. And basically I go through all about these rules. And one point here is on phases of rehabilitation, which which is, so many patients come in and they're in the immobilization phase, and we fit them with an orthotic and keep them running, and they really should be shut down. So there's three phases of any rehabilitation. There's immobilization, where you have to rest the injured part. Then there's re-strengthening, and then there's return to activity. If a runner comes in and he hurts himself running and limps, so he can't run, he has to be in the immobilization phase. Another runner with the same injury comes in and says, I can't run 10 miles, but I can run 5 miles. Well, they're in a different class. They're in the return to activity. You don't have to put them in a cast for that. You just have to, keep them at a pain-free level. I love keep it simple, stupid. And it's the doctor who's stupid by, being too aggressive with some treatments. With my patients, I like to look for simple things that will help them. It's definitely not cost effective if you're running, a multi-million-dollar podiatry practice out there. But I like taping and splints, chew changes. I try to do for things that I think will get better with simple methods. I try to keep it very, very simple for the patient. So even if I think down the line that their biomechanics are so bad they're going to need a custom orthotic, I'll start them with an over-the-counter one. We've got some stocked in our office, and I'll varus wedge it or valgus wedge it or add more cushion to it. So I like doing that thing. I like my patients leaving my office with at least 3 treatments, and one of them being something I've done, whether I've added something to their shoe, whether I put on a Lodi tape or spica tape for their big toe joint. I like them leaving with some hope that I'm going to be able to help them, so they will come back to my office. Ted and I are going to talk about leg length discrepancy later, and this slide reminds me of the I like, with my athletes, I like full length lifts. I use full length lifts because half the time they're running on the ball of their foot, and if you just use a heel lift, it's not going to help their leg length discrepancy. So that's the point. And here's just an example of me taking a blue Superfit and varus wedging it with grinding rubber. I get my materials from JMS Plastics in New Jersey, and I use this grinding rubber material to make either freestanding varus or valgus wedges, or to attach them to something. And then I'll finish, Ben, just with the rule of 3, because it's so important. And this is just the first few pages of this book. I hope that it's full of, common, it's, so much of it's just common sense. And I realize that some podiatrists have so much common sense and some have none. It's like, why did you do that? So, but the rule of 3 is basically when somebody comes in with an injury, say Achilles tendonitis, always look for 3 things. Don't just blame it on a tight Achilles tendon. Look for how they're pronating or supinating. Are they did they just change to a 0 drop shoe from a traditional heeled shoe? Have they just injured their knees so their hamstrings have tightened up a lot? Or, is it during the winter and the Achilles tendon just hurts because they have a stress fracture in the lower tibia or in the talus, and they're coming in and they say, my Achilles tendon is killing me, and really they have a stress fracture deeper. So thinking in terms of more than one cause can be really help you develop a plan to get the patient through their injury. Okay, thank you.
This is great stuff, Rich. And while we're transitioning and bringing in Ted Forkham, who's a chiropractor that's worked with USA Track and Field, and I got to know Ted. Rita made the introduction, and he got me aboard with electromagnetic tissue modification and the things that it's been able to do with bone. And so he's been a great asset, and he's got some really good approaches. He was at our meeting out there in Seattle, and went to a lot of the workshops and got to pick up on some of his techniques for the topic that we're going to talk about next, which is looking at limb length discrepancies. Since I have you up on the screen and Ted's going to join us, I'm going to give you the first salvo. We'll kind of go back and forth between a podiatric approach, chiropractic, and there's plenty of crossover because we're looking at the same anatomy just from different disciplines. One thing that does affect limb length too, to a certain degree, and I just wanted to get your thought. We all have faced the cavus foot. I had a guy today, I took the durometer of the orthotic down, had him in an ultra shoe, had to jump into a Zellero, even more volume in this extra wide just because it was a little too tight with the orthotic. But what do you like as your go-to when they're having that lateral riding what I call the outer rail for the pes cavus foot type? They're putting fifth metatarsal pressure. I added an 1/8 inch of orthopedic felt to my orthotic as a test bed. How aggressive are you? Do you think is that something that would be aggressive enough, or do you like to try to start at a smaller interval like that?
Well, I do it all by gait evaluation and how the patient feels. I want to watch them walk and run, you know, in the shoes you have them in, and try to eliminate that outside roll. I think that's so the outside roll, you know, which is called underpronation, excessive supination, lateral instability, lateral overload, whatever you want to call it. It is so damaging for the lower extremity. So I would rather a patient have a lot of pronation, but I don't tolerate any supination. So I'll start, I'll get them with a shoe that's stable on the outside, like the Adidas NDB, NMD. Sorry, my mouth is not working. The Saucony Triumph, some of even the Brooks Ghost. They're more neutral shoes, or the Brooks Glycerin can work. It only works if you have some sort of orthotic in there, like a either over counter or custom orthotic. But then I add to along that lateral ridge until I see all the supination is gone. I want to see contact phase pronation. We need that for the whole limb to internally rotate. So and if that takes, Ben, 3/8 of an inch, or let's say a quarter,
Right from the get-go. Yeah.
If it takes that much, well, then I have to back it down. I'll tell the patient that's as far as we're going to go, but it's going to take us a couple months to get there, because it's too dramatic a change for your body. So we'll start with an 1/8 inch, and in 2 or 3 weeks we'll add another 1/8 inch, and then 2 or 3 weeks we'll add the third if it took an 1/8 of an inch. But I try to get it all eliminated if I can. Now during that time, if they're not in a good shoe, let's say they're in the Brooks Beast, or one of these Varus bias shoes, and we're trying to stop them being very laterally unstable, then we may not have to do as much. They leave the office with a list of shoes to go try, and then when they come back for their follow-up, perhaps just a new shoe and the orthotic without any correction is fine. But with a lot of cavus foot, of course, they're very unstable laterally, and they need some valgus wedging to their inserts.
And on to limb length. We're going to go back and forth
Hey.
between you and Ted. Since I
Hey,
have you
Ben.
and you have done a systematic approach, just briefly in a couple minutes, if you could hit some of the highlights, and people got to get your book to see, in depth, but you've talked a lot about shoulder drop, looking at length of fingertips. Proceed with how the salient points that you do with your lower extremity limb length exam.
Okay, so when I watch somebody, let me find it on here. I had it and then I moved it out of there. So what I teach my students is when I watch the patient walk, we start from the head. I'm past it. We start from the head and we look at head tilt, shoulder drop, arm swing, dominance to the to one side, and these are all signs of a leg length discrepancy. Sorry, so this is chapter 3 of the first biomechanics book. So we start with head tilt. We're looking to, so these are the first clues that somebody may have a leg length discrepancy. And I'm the only podiatrist in my area that treats leg length discrepancy. I talk to so many podiatrists around the country who do treat leg length discrepancy, but it's actually quite a small amount, other than sticking a heel lift on. Of course, I just blew it. I found that treating leg length can be really, really helpful. So
well, what I like about what you did there is you very accurately gave the pattern that Ted is, of course, very familiar with, of that S pattern of what determines which way the head tilts, and that's going to be dominant. Tell us, to which side does the head usually tilt?
Yeah, so here's a slide that the typically the longer leg has the higher hip, and the shoulder will drop to the longer side, but the head will tilt to the shorter side. So that's the typical pattern. Some people are uncompensated and they tilt, their whole body goes to the shorter side. But this is the slide that shows the typical head tilt to the short side with the shoulder drop. This is the dominance that I like to when I watch a patient walk. Which side are they leaning to? Which side do they hit harder on? A chiropractic trick that I don't use it that often, Ted, anymore, but it's to have 2 scales in your office and to have a patient stand with 1 foot on each scale and where they're balanced, and read the numbers. And if they weigh 100 pounds, one will say 60 pounds and one will say 40 pounds, which is quite interesting. I still do it occasionally, but it was a great technique to use. So you're looking for, anyway, reasons. Your gait evaluation, which I do on my first visit, is takes 5 minutes, and you immediately can, is this a leg length that I'm dealing with? Is it a pronation problem, a supination problem, an instability problem of some other source? You're looking for signs of equinus, etc. But gait evaluation gives you like incredible clues on what you may be dealing with, and then you have to correlate that to the symptoms the patient has and see if it matches up.
Ted, I want to bring you in now, because you've dealt with this in a lot of ways, and of course, with adjustments, you're not always looking to add lifts, but give me your overall sort of philosophy, because I'm sure that in some instances you might see that a structural limb length might require a lift. So I'm sure you can dovetail on some of what Rich has talked about, but maybe kind of amplify some of the points and some of the things that we may not be thinking about that he didn't have a chance to elucidate on.
Absolutely, Ben, and apologies first. I'm in the airport, so there might be quite a bit of background noise. Can you guys hear me okay?
You're good. You're solid.
Perfect, good. Okay, fantastic. So, my approach is basically trying to evaluate from a top-down, bottom-up approach. So is it a functional deficit that's causing a mechanical or a pathomechanics coming from the top down, or is it a pathomechanics as a result of the bottom up, which I think Rich has covered very well in terms of foot pathology. I think podiatrists really shine in that area. From the top down, we can look at all sorts of fascial chains that interconnect the system. So instead of thinking about the body from a reductionistic location, start to think of it more systematically into chains that go vertically up and down the body, from all the way from the head all the way down to the foot, for example, and some of the chains that go diagonal, such as the posterior oblique chain, which will oftentimes show what you're seeing here on this slide, with a head tilt to one side and a lowering of one shoulder as you have tightness of the gluteus maximus, the fascia coming from the iliotibial band, gluteus maximus, into the contralateral latissimus dorsi, which will pull that shoulder down. And oftentimes you'll have that head tilt to that same side because the trap is now in an elongated position. And so there are several aspects that you'll look at that. But when I started out in practice, maybe not quite as long as Richard, I think he's mentioned patients 40 years ago, mine are 35. I was a very tried and true, taking direct method measurements for leg length difference. I send out patients frequently for CT leg length scans and would, fine cone in down to, I can think back to cases where we'd use duct tape to layer out getting a patient to an equal level. And, over time, I think I've changed a lot of my pattern, either that or I've gotten lazy, one of the two. But either way, I've made a pivotal change, and I look more towards a functional approach to what's happening. While, yes, we can balance people out, and I still like using the dual scale method or some of the pressure plate methods for balancing people in terms of their weight distribution. There are challenges with that with patient sway, but also I recognize a limitation to it is that we're just seeing a static posture. And most of my athletes are very active. And so my primary concern is how they're functioning and what their functional response is. So we'll look into approaches of, say, how a person might, as we add a lift in, how's that change their overhead squat? Now, why I use an overhead squat is that you are winding up the fascial chains both posterior, anteriorly, and some of the spiral chains, and tightening them as you get into a squat with your arms over your head. And from there, you can see.
Can you demo what? I know you're pretty flexible. Can you demo what you would want to see if you have a camera angle to do so?
Yeah, let's see. I don't have my. Let me see if I can pull my camera.
Or maybe just from the upper half, if not. But let's see. That's good. We got the visual. Go ahead. Okay, can we get you back on audio and explain what we had?
Yeah, he muted
Yeah,
himself.
Immune by accident. Let me just let Ted know, and while we're
Well,
filling in,
we see-
any
We don't see his screen. We only saw Richard Blake's screen sharing and your picture while he was trying to demonstrate whatever.
Oh, interesting. It didn't screen share. Okay. Did not realize. I saw him, but I didn't realize other people didn't see him. So I guess he didn't have the
Right.
ability to screen share. Well, you did the overhead squat. Are you back with us, Ted?
I am back with you. And
Uh,
so
I see you, but for some reason the cast of characters, I don't know if are you able to share your screen? And we don't have to do it again, but explain what it is. I guess basically, and I'm not super flexible. I don't know if folks can see me, but you're doing this overhead squat, and what are we looking for in that with respect to the oblique chains and so forth?
right. And I actually have a slide deck that shows that, but unfortunately I don't have a strong enough connection. I did send you an email with it in, but I know it's a lot of work when you're trying to run this to peel that up. I went running around through the airport looking for getting some Wi-Fi connection. Never happened. So I bypassed the slide deck. But for people who are interested, what I'm demonstrating is called a National Academy of Sports Medicine overhead squat. And when looking for leg length in particular, you're looking for some asymmetries. There are a lot of other techniques of looking for it, but from a clinical standpoint, as a clinician, this is fast and efficient in terms of your clinic. It doesn't take 45 minutes to go through your leg length evaluation. And what I'm really looking forward would be more of the tissue tension stress evaluation. So whether it's anatomical or compensatory, I'm really concerned about what type of tissue overload is occurring in the body, because as we know, 90% of the population arguably has a leg length difference. It's how they're accommodating to it and how they're overloading with it. So doing these type of functional evaluations are really helpful for determining what's tight, what is maybe not strong enough to support the system or is overloaded. And so, for example, if you see someone who, let's take in for the example you're talking about with the individual that was maybe supinating. And we can look at what might be happening in the foot, but we can also look at what might be happening at the going on up the line. It could be that they have a limitation of hip external rotation. And so now they have a toe in apposition to the their lower quadrant. And that's creating that shear force in propulsion phase off the lateral side of the shoe. Or I've had situations where the person's had a lumbar disc replacement, and now they have a bit of paralysis into the lateral or peroneal compartment. And so you lack that control, and you're getting maybe an imbalance of activity between the deep posterior compartment and lateral compartment, and you're functionally getting a shear off of the shoe. And so just approaching that from a, kind of looking at it from a different standpoint, which used to kill me because I love biomechanics, and I've had the great benefit of working with some cool biomechanical labs. Nike was around the corner from me in Biomechanica. So I've had the chance to hang there, but kind of as I've gotten older, I've kind of leaned a little bit more heavily onto the neurology of how the body responds to inputs, more of the work of Vino Nig, in terms of looking at how those inputs alter how we move in space. And so I'm sorry that my
No, that's
didn't come
fine.
up.
It worked out. You got some great points across on that functional oblique axis, and on that for both of you. Does this mean that we, obviously you've talked from the head down, both of you, and ground up, but what about things like measures of ASIS to medial malleolus, all the things that can affect and confound that? For the students out there and for the seasoned practitioners like myself, is that something that we take it with a grain of salt a little bit more with some of the other functional things that you're bringing into limb length and the compensatory things that Rich just mentioned with the lumbar? how do we still put something like that into perspective? And Ted, why don't you start and then I'll hear Rich's answer.
Sure. And, I kind of look at it the same way I do in terms of the root method for orthotics. So I still use that as maybe a reference point, but it's not like the absolute, where before I'd go the exact angle had to be precise in the orthotic. And now I'm looking at how does a person respond to whatever input I put into the device. And that's how I look at limb length difference as well. So I might go through and do those direct measurements of ASIS to medial malleolus, PSIS to medial malleolus, and take two measurements, compare them, average them out, and approximate a graduated leg length differential based off of that. And also then see how it levels them out on top of their crest. If I have dual scale, I might use a dual scale with them at that point in time. But more than I'll start out at those points and I'll use that as a starting point reference and then move them into functional positions. So doing an overhead squat, doing an activity and seeing if it changes how they move in space, doing that gait analysis that, Dr. Blake was talking about as well, and see if we get some outcome changes with, say, for example, how that head tilts or how that shoulder drops. Do you see the pelvic drop on one side with that change?
Before we get your feedback, Rich, do you ever get patient input when they do the overhead squat if they feel they're putting more weight on one leg, if you can't necessarily see it dramatically, or that's not something that is part of the evaluation when you do that overhead squat?
I have learned through painful slap downs from some high level patients to always listen to what your patients say. There have been some people who came back and told me something very specific, that when they're running down the runway in full vault, that their knee was tracking 5 millimeters laterally at their penultimate portion of their jump. And I'm just thinking, yeah, BS. They're relating it to a specific problem in their back. And more than once they've been spot on. So I always learn to listen to the patient. The bottom line of all of this is patient satisfaction. What makes them feel better? So no matter what we find, it still comes back to what makes that patient happy.
Rich, anything to add on that?
Yeah, I mean, of course, that's what we're doing. We're trying to, patient comes in with pain, low back pain, hip pain, or it could be a heel stress fracture, or something that you're tying into having, a leg length discrepancy. I don't measure in terms of tape measure. I stand the patient up. I look at the iliac crest, the anterior superior iliac spine, and the greater trochanters. The greater trochanters are more a true reflection of leg length. And the other two are subject to pelvic tilts and scoliosis and all that stuff. So I'll measure that, I'll put lifts underneath of 3 millimeters each to level them out. And then I will start them on a lift. And usually, it's if say the average person has 3/8 of an inch or 1/4 of an inch, I don't mind going, an 1/8 inch every 2 weeks but if they ever put another lift in to balance themselves out and they feel worse, then they should stop until they see me. But it typically works well that way. I've always found tape measure being unreliable when I've tried to teach it. And if I can't teach it, then I shouldn't lecture about it. But I do take on really difficult, overweight patients or patients who are in, a lot of back pain. I'll take a standing AP pelvic X-ray, barefoot, of course. And the nuance with that from a podiatry standpoint is that if they have asymmetrical pronation, or one foot's more supinated than the other, which means about the same, then you have to balance that out. I have to go down to radiology and put them in subtalar neutral before they take the x-ray. I work in a hospital, so it's pretty easy for me to run down to the first floor to do that. But or if you have good orthotics that they're in, you can actually do the x-ray without. But it's just one standing AP pelvic x-ray, which I don't do the whole scanograms since I'm not going to do surgery on the tibia or the femur to balance things.
Perfect. Well,
And
I'm going to
can I
let
jump
you
in
have
on
last word, Ted. Go ahead.
Sure. And I have to say a little caveat there is, from the tape measures, I would not do that on a heavy person. It's impossible to come up with any level of accuracy. So, if you look at the pool of people that I have, they are generally active athletes. And so their body, I'd say that from the athlete standpoint, body composition wise, they're at 15% body fat, that's really high in the standard group. I do have some people on the far other end of the scale, but not often. But it does kind of pose the question is like, well, we're only seeing leg length difference on skinny people because you can see the effects of it more readily. And so I think that's a challenge. But I tend to use the CT leg length scan a little bit more simply because I know how hard it is to perfectly position someone in front of that bucky to get the AP pelvis to be statistically really reproducible. And I know that CT scans have their own issues as well. The amount of radiation is going to be similar and the cost is fairly similar when you do the leg length scan. And part of it, especially when I go to the heavy person, a lot of times I'm looking more for, well, what's the joint distance? How much degeneration do they have on their left versus the right at the knee or hip? That's helpful for that heavy person. In terms of the athlete, especially if it's a cyclist, then I'm looking for more of that true measurement. What's the femur length to the tibia length? Because now I can dive them off to a biomechanist that can help them with their bike fit a little bit more precisely.
Well, I love that we've got you both here on the screen together. And if nothing else, I hope everybody gets out of this that, sharing thoughts with different disciplines is a good thing. And, we hear things from like the American College of Sports Medicine, picking up on those techniques that you use for functional measurement and neurologic input. And I think it's just great to have that crosstalk. And so I look forward to more of it. Next on deck, we've got Brian Kentner. He's going to he has a consulting company, the Printed Foot. He's studied in China with some of the techniques with 3D printing, been on the cusp of it. Welcome, Brian. And you're going to talk to us today on some of the new things happening in 3D printing and some of the practical things that we need to know if we're going to invest in that technology.
Yeah, exactly. I'm going to go a little bit more into some of the theory about the actual printing part, a little bit less about the software. So
and before we forget too, tell us about where you are with your company and if people do want to reach out to you, how would they do that?
I mean, my website is the printedfoot.com. We specialize in the 3D design software. I'm have a 3D scanner that uses an iPhone's true depth camera to keep costs down for a clinician. And we're working a relationship with a couple of 3D printer companies. Right now, we were making, our own in-house, but now I have a relationship with Mosaic Manufacturing, which is very helpful for automated 3D printing. So our 3D prints will actually be able to take it off the bed automatically and run behind the scenes. So you could put a printer running all weekend and have multiple prints going. But anyway,
well, give us the nuts and bolts about what we need to think about. I know.
So the first thing we're going to go.
Dr. Spector got me into this, and then I met you. Go ahead.
Yeah. So the first thing we're going to look at is what materials you're going to print in. So very, quickly, TPU is the one that most of the orthotic printing you're going to see is, and that produces a device that kind of looks like it's been carved from an EVA block. The way TPU is, it's a very flexible material, so you need actually all this form to be able to give you the structure so you have resistance here. And then we can change the resistance by our slicing pattern, and we'll go into that in the slideshow. But I just wanted to show you this is one TPU device. It's very flexible. You're not going to snap it. It doesn't have skin, cytotoxicity or anything of that nature, so it can't come in contact. Although I do recommend a layer of cushioning like you do with the standard orthotic. And then new to 3D printing, at least for the FDM, we have polypropylene, which you don't have to use it just for a AFO, but something like this you would not be able to produce in TPU because it's not going to be rigid enough. This is flexible, so it's not going to snap like some of your other materials you see, like I guess the standard would be just anything like whatever. I'm having a mental block, but the polypropylene is very good because you can make a standard shell like a traditional orthotic, and it's not going to snap either. It has some flexibility, but you're going to have the rigidity. And now from there, we're going to go ahead into just a quick little bit. They had some pointers that some of the other lecturers talked about software, so I'll just do a fast bit on my software and showing you things that you can do. So going to our first lecture, you have the ability to overlay images. So if we do pressure scan on somebody, I can overlay that pressure scan. I can come through and then, say if we have an area where there's a high pressure, we can add a device like the faces are in my way. All right, there we go. 4-foot met pad. So I can take, and my computer is going slow, so there we go. All right, there we go. So I can actually see that where it would overlay to the pressure that's on the foot.
Lost the audio for a moment there, Brian. Audio.
Sorry about
There
that.
you're back. You're back.
All right, I was trying to move my one screen out of the way.
You're good.
So we can overlay the foot or overlay the foot pressure, and that allows you to put any modification that you do exactly where you need it. Or we can cut out an area for like an increased pressure to make something that I will go through when I'm talking about 3D printing, but I can segment areas, and that would allow me to make an area of different pressure for different regions. So I can like spot an area, where we have, and again, right now I'm running 3 screens with my Zoom, and I'm on a laptop, so my speed is going a little bit slow. So we're going to go ahead and get out of here, and I'm going to go to the presentation part. The last little bit that we can talk about here before I leave is we're talking about, for limb length discrepancy. We can go ahead and add automatically for a whole limb length. We can say, obviously we're not going to add 10 millimeters, but we can increase that and add it to the entire insole. Or again, that's something that you can just go ahead and add to just a heel lift. And I guess I have one too many screens running. So,
We
but
can
yeah,
hear you okay, and it's presenting okay.
yeah. So the joy of 3D printing is all the little things that you would normally do with felt and, things that you'd modify an insole on. You can go ahead and modify it on your screen, and only takes a second. Add a limb length, bring them back in 2 weeks, redo a, modification. If you're only increasing to say like 2 millimeters a week, trying to get them used to the limb length, you could add 2 millimeters, add another 2 millimeters. The 3D insole would be, something you can recycle. So that is, use of the plastic. You don't have to have a stock of standard over-the-counter insoles in the office to modify. And then I will just go ahead and talk a little bit more about 3D printing and a little bit less about just my software. And this will be more useful for any software that you have 3D printing for. Okay. And, oops. So basically 3D printing is just an additive manufacturing. We're just going to add layers upon layer. For the orthotics to be made in office, there's a lot of different ways you can produce 3D, printed objects. But for an office, the easiest one is the FDM printer. It has the lowest cost point to enter. It has the least amount of vapors and smells and the least amount of post-processing. So out of everything that you look at, take away from the different types of printers in your office, really the only one is going to be the FDM/FFF 3D printer, and that's your standard. Like you can even think of a over-the-counter like Creality type printer, and that would be into that range. That's something that you can have in the office and have it print an orthotic roughly in about an hour, depending upon your settings in the printer that you have. So next we're going to look at materials. And again, the materials that I recommend really are only going to be two right now for orthotics producing with the, at your office. And TPU is going to be your standard material that's very flexible. You can change the durometer so you can have your diabetic insoles, although right now you're not covered medically for diabetic insoles that are 3D printed. However, the ability to, produce a device that would offload an area of ulceration, have a decreased pressure for a sore is much better with 3D printing and TPU. You can also do the polypropylene. I use that more if I'm sticking with a standard traditional orthotic shell, or if I wanted something like an AFO where I needed full, control of the foot and ankle. And so that's when I'd go into a polypropylene. And again, both those materials will meet your requirements for any type of safety for skin and chemical interactions, so you don't have to worry about those materials. Although TPU, there's a little bit more additives and variation between manufacturer, so you just have to verify that the manufacturer that you're getting your TPU from does adequately have the precautions and coverage for your government issues. But all right, so TPU now, the basic, I was talking about the level of durometer, the amount of stiffness and the amount of support you're going to get inside a orthotic. That's pretty much controlled by what's called the infill. And the infill is just the inner layer. So when you produce an insole, you're going to get a STL shell, and that's just the outsole of the insole. And that's the outer layers. Now, the inner part of the insole, especially for the TPU, is where you're going to be getting all your control. So in order to control the TPU, you want different parts to be different, durometer to be stiff or softer. You're going to have to control some of the materials. So the two basic infills that I'll use are, one is a line infill, and that forms nice squared vertical columns. So the Z shelf is layered one on top of the other, so it is a straight down pressure. And with this one, you have really no compression because you're pushing down into a straight column. So it is very, you can make it very rigid, or you can, spread them out a little bit and have a little bit of variation. But this is one if you want something that's going to be a bit stiffer. Now, TPU will always be flexible, so it will have that bend. It just, when you compress it vertically, the durometer level will increase when you switch to this one. The other one that I like for any type of flexibility or cushion is called a gyroid infill. In this one, you have a squiggly line. It's a little hard to see in this picture, but it's also offset on the Z axis. So as you're building material, the Z steps over a little bit to the side. So if you think about it, it's more like a spring. When I push down vertically on that, depending upon how close the lines are together or how thick those lines are, it'll have more or less rigidity to it. But this one is a very good material for your flexible, so you'll get a little bit of compression with it, and you will be able to control those compressions with a couple other settings. And those settings that we talked about are, one, going to be your infill density. So if you have an infill and you're only having 10% versus 20% versus 30% for the density, you can see you're putting down more layers in between those area, and that'll give you more compression, or obviously the more material you have in there, the firmer the durometer is going to be. There's also, different types of TPU. So you have the number afterward, which is like their standard durometer. So you have like an 87, a 93, or a 95. Though that's how firm that material is. So you can change that a little bit, also just by changing the material. So if you printed something in an 87 versus a 95, it's going to vary how squishy that insole is. but you need to play a little bit if you're going to be doing different materials that are outside what your manufacturer recommends. I recommend getting a roll of material and just doing test prints and comparing it to what you're used to. So that way you can find out, where that durometer comes. Because right now, every manufacturer has different ones. And even if you change a color in the same manufacturer, those additives will affect how that material will print. So we're still at the early phases where there is a little bit of playing that you have to do with your materials. But once you have the materials that you work on, then you can start controlling things a little bit easier with like the one, like I said, the infill density. The other one is controlling what's called line width. So you have to go through your settings. You look for line width. This is going to be your normal shell, but then they also have what's called the infill line width. And that is what that infill lines, that's how wide their material is. So by controlling those lines, if you make it thicker, you're putting more material down in each little spot, or you can have it thinner and put less material down, and that will directly affect your durometer. So if you need something that has an area where you need more control or less control, by just changing that infill line width in that region, you can control that. And so this was what I was showing you on this site. If you have a spot, say here where this red is, if you had an ulceration and I wanted to offload this region, in the software, I just click around the region, make a segment, and then when I go to my slicer, I can change the line width, and that'll control the properties for the different segments. So you can have a orthotic with different properties based on region. Every software is going to be a little bit different, so I'm not going to spend too much time on how you do it. But once you get that area segmented inside the Cura software, you can select different models. So I selected the region for what that segment is, and I changed the line density for that to a 0.4, and the line density on the outside part is stayed at the 0.8. So it has, 1/2 of the amount of material within that center section. So that area where that little marking was of their high pressure area, I can now offload by decreasing the durometer just in that spot. In addition, you could also do just a cutaway or make a simple relief in that area. And it looks like we have a question. Yeah, so, okay, so we're having some question about the software. So I'm gonna, once I end this, I'm on this actually the last slide of my slicing software. I can go back into the, I just needed to close a tab or two. Stop share. All right, hold on. Joys of having a slightly slow laptop. I can only do so many functions at one time. So apologies. Let me just reload my software and then switch back to that screen.
Do you find when you change, Brian, typically because it's additive, I had a patient today, it was the same pes cavus foot type. And he said, I feel a lot in the arch, and I had used a softer one, an S90. And I added a valgus outrigger kind of, 4-foot extension post and into the heel. But do you find that you find yourself grinding down or reprinting more to lower the arch? Which do you use a grinder to try to take it down ever?
You can, yeah. I mean, the material you can grind, which is very nice. So at first I will grind it, but the main thing I love about 3D printing is once I have it designed down, I can reproduce that with complete fidelity. So if I grind it down and I say I take like a millimeter or two off, I'll go back into the software and I'll do that modification and print them a new pair, and then let them leave with the new 3D printed pair. So I might have just a quick little grind down in the office, have them test it before I print the pair. But I'd rather print the pair because that way,
More
when
integrity.
the patient leaves and they come back and say, "Oh, that pair is the best thing ever. Can I have that again?" It's not just okay, I ground something down, but how much did I grind down?
And
I'm
you're
not
worried
really-
about that outer eggshell of the thing where sometimes it gets a little squishy where you have that grind if you go too far over the,
Yeah. Well, that's true. You only have so
a
many.
few millimeters.
Yeah, you only have a few millimeters to play with. So once you go through, like you said, you can go through the orthotic. So that would be problematic. So right now, what I did was I selected the 3 main points for the foot on your scan, and that's the first, fifth, and center heel, and that acts as your ground plane. And now you have your device inside here. What was the question that I had? Okay, I was asking about valgus and varus. So yeah, simply for valgus and varus, it's nice. We can go ahead and just take the orthotic. You can have a center line. We can also do this to the foot before we bring the foot in. And so I can do I can do a wedge just on the forefoot or rear foot. We can put our center of axis through, and we can change our axis heading if we wanted to match more of a subtalar neutral, or if we just wanted to cross the entire device. And then you can just go ahead and just change the forefoot, or go ahead and do the same thing for the rear foot. So all of this can be done on the fly within the software. And my timer just went off, so I am now at my limit of where I'm at, but that's just a quick little, basics. And then again, for heel lift, we can go through and just raise up the heel if we wanted to. We'll bring this to a lateral so we can have a better view, but just bring the heel lift up. And then I can change where the bend position occurs. So I can bring it forward or backward within the orthotic for where I'm bending it. But at the standard is right at the, metatarsal plane. And then the other thing with 3D orthotics, you can change the shape of anything that you want. So whatever you do, you can undo, and any shape, whatever the shoe shape is, I can overlay the foot model, or something like bring in a insole, and you can overlay that directly on. So you can make your insole exactly match whatever foot shape you have. So that would just come in here, and I'd pick the insole and have that leaning to the left. So then I can go ahead and use that as my shape to go ahead and adjust. But I am at the end of my period, so I will stop the share because I don't want to drag everyone over. Was that enough of a, I guess it was Dr. Blake, was that enough of a quick little overview for the valgus and varus that you were able to get a little bit of info from that? Trying to do where I just, I don't want to focus on my software mostly. I wanted to just kind of skim my software and focus a little bit more on standard orthotic printing for any software.
No, Brian, that was great. That was great. It was good to see. Unbelievable technology.
Yeah, I love the fact because, I used to do the same thing where I'd keep an over the counter and all the different sizes and different shapes, and you have a whole closet to these devices, and then you have the person come in and you do all this customization, and then if they come back say, "Oh, can I get that again?" You're like, "Well, no, no, I can't do that exactly, but here's something similar." So
Right.
with this, any CAD, changes you do, and the other thing I like is you can do it in stepwise. So like if you're changing someone, adding a limb length discrepancy is a great one. You could add 2 millimeters, bring them back in 2 weeks, add another 2 millimeters, get to the point where you have it set at what you want, and then forever that's their future prescription, and you can change the shape of the orthotic or make it fit different shoes, but still use that same prescription from the first one.
What I
And
liked
it
about
works
your
pretty good.
presentation is how you just took it to the textile level, even in terms of the stacking of the columns of the grid and how that affects the compression and durometer.
Yeah, I mean that's the thing.
Great
People
talk.
love to talk about 3D printing, but they don't go into how all these other factors affect it. So I was trying to hopefully I got that across. But it's a little bit of playing around with. I'm working on my own slicer that will do a lot of these for you. But for now, there's a billion free slicers, so just take the slicer and start playing with it. And you can even pick up a printer for like $200 at a Micro Center or something. So 3D printing is definitely coming down. I recommend starting with a home version and playing with a 3D printer before you spend $7,000-8,000 and jump into it.
Well, believe it or not, folks, we are in the home stretch. I positioned these last two guys right next to each other because they're both very knowledgeable and both are going to have some good views. Wrapping up, we're going to have Dr. Bartold, Simon Bartold, back to the virtual podiums talking about sports-specific footwear. And right there behind him is going to be Golden Harper talking about run shoe selection and surfaces. And there may be some crosstalk that they have on things they may want to ask each other. But let's bring it back, Simon, if you're ready. And if there's a gap, Simon, I see your icon up there, and he might have had a connectivity issue. Golden, are you out there in cyberspace?
No, I'm here, mate.
Oh, there you are. Okay, perfect.
Yeah. Okay. Share screen.
And you got some wonderful designs that I have on YouTube. Some of those soccer cleats and actually a very specific sport. I think you designed a shoe. It was your sort of your Mona Lisa of shoes. So I'll be looking forward
The
to that.
Solomon. Okay, here we go. Okay, thanks, Ben. Hopefully you can hear me okay.
Better?
So what I thought I'd do is, rather than sort of take a scattergun approach and look at a whole lot of different stuff, I thought we might look at one example of and ask the question, do shoes actually make a difference or not? And there's no better example of this than the new so-called super shoes. Well, they're not so new anymore, but I can't really remember a time in my involvement with athletic footwear where a particular genre of shoes has made a bigger impact. Minimalism obviously was a great discussion point, but this is another different level altogether. So I thought we'd pick on this one and just try to get a bit of a handle on what it does, and particularly whether it does have an impact on performance and also on injury. So what's the rub here? Let's have a bit of a look and see if we can get a bit of a handle on what we're talking about here. And I want to give you a bit of a timeline here of the marathon world records so that we can understand exactly what this is all about. So this is a timeline from 2002 right up to now, pretty much. And you can see some great names here, the great Kenyan runner, Paul Turgott, going right through to Wilson Kipsang. And if you look at the time differences here between when marathon world records fell, look at the chronological order here, so in terms of years, and then in time. So you can see that with all of these differences here, we're talking averages of around about somewhere between 15 and 30-second reduction in the world records, right up to 2013 when Wilson Kipsang broke the world record. Nearly all these records marathon course. So right up 2013, and then Dennis Kimetto, oh, that time is not correct. That should be 02, I think. Yeah, not 20. Dennis Kimetto brought it down by 34 seconds. So just look at these times here, 34, 15, 23, 27, 29, etc. Then this guy came along and he world record in Berlin by 1 minute 43 seconds wearing a prototype of a brand new Nike shoe. He then proceeded to be involved in something called the Ineos 159 Challenge, which was held in and which absolutely blew my mind, to be quite honest. And he was the first man to ever go under 2 hours for the distance of the marathon, 26.1 miles, 42.2 kilometers, and he did it in 1 hour, 59 minutes and 40 seconds. Absolutely extraordinary. I watched the whole thing live. Now, of course, this was extremely contrived. He had paces with him. He had a laser pacing line that he kept up with. It was a very interesting project. Every nuance of this course was analyzed by Nike. In fact, apparently they were able to look at the topographic map of the entire course for every millimeter of the entire course to figure out what the undulation in the course was. They monitored all of his nutrition, his sleep. They held it in Vienna because it was very close to the time frame where he lives in Ethiopia. But that notwithstanding, look, guys, can you just hang on for 1 second? You cannot disturb me. You cannot disturb me. I'm in the middle of doing a presentation. Sorry, guys, I'm home alone dad at the moment, so I've got 2 kids home on school holidays who are coming in. So I've just told her to buzz off. So anyway, this is an extraordinary situation, and I think what we need to do is take a couple of steps back and try to figure out what these shoes actually are. So what defines a super shoe? Well, there never has been a definition as such, but I define it as this. It has to have a carbon fiber plate. It has to have a large volume of foam with a high stack height, and it has to have a defined rocker on the midsole. So these 3 things for me are the factors that are essential for a super shoe. Which is the most important? Well, we're going to drill down on that in a bit, but let's just discuss this. So, where all the hoo-ha started with what became known as the carbon fiber plates in footwear, are actually not that new at all. They've been in use since the mid-1990s. Our esteemed colleague and my great friend Ben O'Neill was very involved in the development of carbon fiber plates in the late 90s. But the very first shoe to actually employ a carbon fiber plate was here. Now, this was a plate that was not a performance addition. This was a plate that was just designed to try to maintain some integrity to the shoe, because you can see that they've cut away nearly all of the midsole here. So it wasn't designed in any way as a performance parameter. It was just designed to try to keep the shoe together. But the first commercially available running shoes with a carbon fiber plate, may surprise you, were actually made by Fila, a company not known for technical running footwear. But in fact, back in the day, they were extremely technical, and they built this particular shoe, which was the first shoe ever to employ a carbon fiber plate with a view to improving performance. Now, this was the shoe that Paul Turgott actually was wearing. He was a Fila-sponsored athlete, and he broke the world record. Unfortunately, he did not do it in this shoe because at the time he broke the world record, he had transferred over to Nike. So Fila were not able to claim the world record. But this is the first commercially available carbon fiber plated shoe with performance in mind. And there you go. Paul Turgott, Berlin Marathon, September 28, 2003, ran 2:04:55, but he did it in a Nike shoe. Adidas were definitely the pioneers throughout the 2000s, and this is interesting to me because this is some of the stuff that Ben O'Neill was very involved in with his work with Adidas, and they've developed a shoe that was called the Anti-Star Comp, and this had what was called the carbon fiber pro plate in it. And even today, I love the look of this very beautifully engineered carbon fiber plate. Not easy to engineer carbon fiber. It's not a very user-friendly material, but they built this shoe and it met with some success. And it was probably the forerunner to what we saw. Now, one of the very interesting things here is that there is a line of succession of researchers who are working on this. So first up, we had Ben O'Neill, who was working on this shoe with Adidas. And at that time, he had a PhD student by the name of Darren Stefanition. And Darren Stefanition sort of carried the baton through the 2000s working with Adidas. And Darren Stefanition had a PhD student by the name of Gung Luo. And Gung Luo is generally regarded as being the person who was responsible for the Nike Vaporfly 4%. So all of this carries on through a line of succession of people who are involved in carbon fiber plated shoes. And this is all come out of this fantastic footwear research centre, the University of Calgary's Faculty of Kinesiology and the Human Performance Laboratory. So that's the line of succession there, going through to Gung Luo, who was very involved in the development of the Vaporfly 4%. So who's involved in the super shoe arms race? Well, this is quite interesting because now the answer to this question is, well, pretty much everyone. So initially, for many years, Nike, this shoe first appeared in 2016. in the Olympic trials for Rio. And Nike pretty much had it to themselves until about 2019. And then everybody sort of looked at it and gone, holy cow, these shoes are really doing something, we've got to jump on this. So now I think it's gone from one manufacturer of super shoes. I think there are now sort of who are building shoes with these three characteristics. This is the Nike Air Zoom Vaporfly. I'm going to be putting shoes that are sort of historically correct here. So these are not the absolute latest in 2023, but these are the shoes that are of historical importance. So it's got a PEBA foam. So some people call this PBAX, but this is polyethyl block amide foam. These foams are very, very interesting because they can be, it's a two-chain amide, and you can basically manipulate the molecules of the amides to make the material either very stiff and rigid, like you might see in the base plate of a football cleat, to a foam. And then you can also manipulate the foam to be either more or less resilient. So it's a PEBA foam. The other advantage of PEBA is it's about 20% lighter than any other foam on the market. And it has exceptional resilience. So it has a resilience of somewhere in the vicinity of 78%. The next best is around about 65. So it's a very, very important foam. I'm talking about Zoom X here, the proprietary Nike PEBA foam. It weighs 227 grams, which is right in my sweet spot for a running shoe. When I'm involved in the design of running shoes, I won't let it get on the market unless it's under 250 grams. It has to be light. So fulfilling a very simple law of physics, F equals ma. If you increase the mass and you multiply it by the acceleration of the limb, you increase the force. So you've got to keep the weight low. It's got these very interesting Zoom AirPods in the forefoot. I think these are really important because I'm not certain, but I think that these filaments in the Zoom AirPods are able to recognize ground reaction forces in all three vectors. So in other words, vertical, horizontal, and side to side. And no other shoe has ever been built that can do that. And we'll talk about the potential advantage of that in just a little bit. Stack heights, 39.5 millimeters in the heel and 35.5 in the forefoot for a 4 millimeter drop. Why 39.5? Well, quite simply because World Athletics said you can't go over 40 millimeters, otherwise the shoe's illegal. So Nike's taken it right up to the limit at 39.5, as Nike do. It's got a rocker. How significant is the rocker in comparison to the foam and the carbon fiber plate? I'll go on record and say I think the rocker is probably the most important thing in a super shoe. It's fulfilling something called the Ruina Gomez model, which is basically a model of a half bicycle wheel, and it allows for an improved rollover time in the shoe, and I think it's incredibly important. It brings into discussion this whole concept of the geometry of the shoe. So these days with shoes across all categories, you can think tennis, basketball, running, trail running, you're tending to see shoes with less stuff put in them. So we don't tend to see shoes with a lot of components anymore, but you do tend to see shoes that have very distinct geometric characteristics that manipulate the biomechanics of the shoe and the way it interacts with the runner. That's another whole lecture, but it's very interesting. So rounded contours for basketball, much more important than the old straight sidewalls for basketball, because basically you've got a much greater surface area contact with the court, and you're not landing on a knife edge. So you can do all sorts of things with geometry. Ben, you alluded to a shoe I was working with Salomon when I was living and working in France called the Predict, which is probably my most cherished project. And the Predict was all about geometry. So it was a completely decoupled shoe. In fact, the upper of the shoe was made in the factory that manufactures all the bras for Victoria's Secret. And the reason we did that is that those guys are absolute experts in form fitting. And so it was a two-piece upper, and the whole back part of the shoe was built in the bra factory. The shoe was incredibly flexible, but we did a huge amount of testing on that shoe, and we could show gigantic reductions in joint moments. It was extremely stable despite being very, very flexible. And it just blew out of the ballpark this concept that you need stiffness and rigidity for stability. I'm here to tell you, you do not need stiffness and rigidity for stability. You can do it with the geometry of the shoe, but that's another whole story. So let's continue. So this is a very interesting shoe. So if we start with what we call, let's call it the 4% or the Vaporfly family, which is now evolved into the Alphafly. These shoes now have multiple peer-reviewed data to tell us that they actually have a performance advantage, and we'll talk about that in just a moment. This is very interesting. This is Eliud Kipchoge just about to go over the finish line in 1:59.40 during the Ineos 159 challenge. And this is some data from Walter Hoogkamer. Walter Hoogkamer was working with Nike at the time, and he did the original study on the Nike Vaporfly 4%. They took 18 runners, they all wore size 10 shoes, and they could all run 10K in under 31 minutes. So they're all really good runners. Every single one of them used less energy running in the Vaporfly than in any of the other shoes. So they compared it to two other Nike shoes. And the average difference between the Vaporfly and the other two shoes was 4%. It went up as high as 8% in some runners, but the average across all 18 runners was 4% at a p-value of 0.001. So highly, highly significant. That kind of blew people out of the water, because this was the very first time that we had a scientific study published in a respected high impact journal from a very respected researcher who is very respected. It was the very first time where it will make you run with greater energy efficiency. And to put this in perspective, so a 4% difference in terms of the energy expenditure equates to about a 2% difference in the time to run a marathon. 2% for an elite runner is absolutely astronomical. It's a huge, huge number. So having a look at some of the others, Saucony jumped on the bandwagon pretty early with Endorphin Pro. It has an S-shaped carbon fiber plate. It also uses PEVA foam, but it's a different recipe to Nike. Weighs in at 221 grams, so nice and light. Again, huge stack heights, 35.5, 27.5. It's got a rocker, so it qualifies on all levels. We've got no published research for this. Hoka came in with a Carbon X. Basically, they said the carbon fiber plate was there to hold the rocker. It was not there for any other reason. You can see it insinuated between the two-piece foam here, two-piece foam midsole, two-layered foam. It's a whisker under my threshold at 249 grams. So far the heaviest of the group. It's got lower stack heights, but it's got the traditional Hoka 5mm drop, and it does have a rocker. There's no published research on this shoe. The Brooks came into the market with the Hyperion Elite. It would be fair to say the Hyperion Elite was an absolute bush pig of a shoe. It was generally canned. It was seen that Brooks brought this shoe to the market very, very early on. It had the carbon fiber plate, but it had a DNA zero foam, as they call it, which is EVA with additional air. It was extremely light, 191 grams, had a defined rocker. You can see the stacks here, 8mm drop. The average lifespan, advertised lifespan, was 50 to 100 miles. Not much good to a marathoner training, I wouldn't have thought. There's no published research on this. This shoe, the guys at Believe in the Run called this shoe dead on arrival. So it reviewed very, very badly. But Brooks redeemed themselves with the Hyperion Elite 2, which is a very good shoe, or was a very good shoe. Full-length carbon plate. They changed the foam to a different one, EVA with injected nitrogen. It's a bit heavier, but still very light. But still, we've got no published research on this shoe. Skechers are a very interesting company to me. This is the company that built the Shape Up shoe, which was a shoe that they used Kim Kardashian to advertise their shoe, which I don't think anything more needs to be said about that. But they sold a truckload of shoes. They wore a $20 million libel suit, but they probably made $100 million out of that. And with that money, they proceeded to establish a fantastic biomechanics lab, employ some really good people, and they're now building some great shoes. This is one of them. It's got a full-length carbon fiber plate. It's got a very interesting foam. We're not quite sure what this is. It weighs 164 grams, if you don't mind. Extremely light. It's on a 4mm drop on relatively low stack height. It's got a rocker. Now, so I'm not sure whether it's been suspended or what's going on, but still, we only have Nike who have published any data on these shoes. I need to talk quickly about Adidas because they've been such pioneers in the shoe. This is, to me, a very traditional looking shoe, the Adi Zero Pro. It had a boost insert in the back part of the shoe, and then this is just an EVA midsole here. We don't know what the stack height is. It had no rocker. It had a tuned carbon fiber plate, which is something that, to me, smacks of Ben O'Nig. He's very into tuning these things. Two-piece midsole, as I said, with boost and light strike. We don't know what the weight is, and we've got no research. But that's an old shoe now. The Adios Pro, a really interesting shoe. Potentially, I would say, the only shoe, maybe with some of the ASICS product, that can go head-to-head with the Vaporfly family of shoes. Pronounced rocker. Really interesting carbon fiber plate set up with 5 different energy rods. I'll show you those in a minute. A 2-piece midsole for Light Strike Pro, so they ditched boost, which is very heavy. It comes within the defined weight group for me, but still no published research. These are the so-called carbon fiber energy rods. You can see it's a very, very interesting setup, and this shoe is fast. So it has actually really taken the game up to Nike with this particular shoe. So finally, just very quickly talk about the Fuel Cell TC. New Balance are making some very nice shoes at the moment. Full-length carbon fiber plate. It's over the limit for me. It's the heaviest of the group at 259 grams. Relatively low stack heights, although it looks bulky. It's got a 10mm offset, which is quite unusual for any of these shoes. It's got a pronounced forefoot rocker, but no back rocker, so we call this toe spring. But it's got no rear foot rocker, and we've got no published research on this shoe. Where's it all going? That was bad. I think there's some very interesting stuff happening here, and where it's going, as you can see, the reason I use this slide is I talked briefly about geometry. Look how bulbous this shoe looks. Look at the geometry here, the rounding contours. I've talked at length to Ben O'Nig about this, and we both agree that this is the future direction of footwear, that we need to be looking at geometry here. We need to be looking at how you can manipulate, particularly the midsole, to change the way the shoe performs. This has got a big flare on the forefoot here, and the idea here is that just without doing anything else to the shoe, you can provide a very stable forefoot platform for propulsion. All of this, sort of the way all this stuff comes together, potentially with a series of different carbon fiber plates, although WA World Athletics has banned multiple plates, but we've got also the use of different foams sandwiching a carbon fiber plate. Great potential in this. So I think this is what we're looking at moving forward. Now, the big question here before we wind up, do the super shoes affect performance? Yeah, they do, but once again, we've only got data on the Vaporfly family, but we have extensive data on this now from multiple multi-center studies showing at least a 4% energetic advantage. The Vaporfly Next Percent has an effect at the level of the first metatarsophalangeal joint in terms of both negative and positive power. It's reducing the net energy loss without increasing the mechanical demand at the ankle. That kind of defies all the laws of physics. So as we all know, you can't create or destroy energy, you can only shift it. But one of the really interesting things, and this is a paper from Maria Farina, that they have not yet been able to understand where the mechanical demand is going, but it's definitely not going to the ankle, and that's super interesting because that's where we'd expect it to go. Is there a benefit? Well, the Nike Vaporfly 4%, focus on this one because it's the original. It appears to provide a notable protective benefit with regards to attenuating muscle soreness, damage, and inflammation. In other words, delayed onset muscle soreness. This actually, when I heard this paper presented in Calgary a couple of years ago, this actually really blew my mind, because what this is saying is there's not only a performance advantage to the shoe, but there's a training advantage to the shoe. So if you wear this shoe for training, you are going to have less DOMs, therefore you will be able to train harder. And for an elite athlete, you know, the equation is to increase performance, you can equals training or something else. The only other way you can go harder is to take an illicit drug. That's the only other way you can do it. So it's a really big deal if you can train harder. And it seems like this shoe is allowing athletes to train harder. And so this is associated with this functional benefit. So away you go. And this is from Brent Kelly and co-workers from that same conference. So just to underline this, the shoe is not only providing increased energy efficiency, but it's also reducing the load on the musculoskeletal system, which means you can train harder. And that's just a really big deal. What else might it be doing? The other thing it might be doing is it might actually be reducing the amount of vibration going through the system. So just very quickly, and this is a complex area, something I worked on extensively when I was with Salomon in France. One of the things that's not discussed in terms of impact load. So we talk about force, we talk about pressure, we talk about accelerations, we talk about joint moments, but we don't talk about vibration. So when you hit the ground, when you run, you create a shock wave that goes through your system. And that shock wave has to be attenuated, otherwise it will affect your vestibular systems and you'll fall over, okay? It's attenuated in two main ways. The most important way that you can reduce vibration going through the system is by contracting your muscles, okay? So as the muscles contract, the vibration is reduced. Now, the only problem with that is if you contract your muscles more, you get fatigued more. So you get more tired when you run. The other way you can do it is with the shoe, okay? So I'm going to put it to you that what we saw with Eliud Kipchoge in Vienna on the 159 Ineos challenge, when if you look at the video, he runs across the line, he keeps on running, he's waving to the fans, he's jumping up and down, he goes and hugs his wife, and he looks like he could turn around and run another 26 miles back in the other direction. Contrast that with Ryan Hall when he ran the best marathon time for an American marathoner. He looks like he's about to die when he goes over the finish line, literally. So there is something going on with the shoe that is reducing fatigue. I have absolutely no doubt about that. And I'm pretty sure it's got to do with vibration dampening because he's not having to contract the muscles quite as much. And that probably had something to do with that AirPod bag in the forefoot with the filaments that are reducing the ground reaction force in all four directions and probably also attenuating vibration better. That's the theory. I'm pretty confident that is what's going on, but that's for discussion. Here it is. You can see this is the shoe he wore, a prototype of the Alphafly Next Percent. Very, very interesting. The other big question here is, can the shoe cause injury? Well, they definitely change running style and biomechanics. If you change biomechanics, then you always have the possibility that you are going to injure an athlete. So we do need to show some caution with these shoes. We've got really good data that both minimalist and maximalist shoes can be implicated with increases in site-specific running-related injuries. You could say exactly the same thing about traditional profile shoes. There's no question at all that shoes can cause injury, running-related injury. What's the specifics for a super shoe? In relation to the Nike Vaporfly, again, it's our benchmark. We've got no other research. Any muscle damage to the runner might actually be ameliorated by using extremely compliant running shoes, such as those evident in the Nike Vaporfly design. So this is from Kandau, is also underlining what Brent Kelly found, that it probably reduces the load on muscle. So it has this very positive effect, but also particularly think about what might be going at the first MPJ and what might possibly happen. Finally, will these shoes work for everyone? Of course they won't. They can't possibly, because everyone's different. So I run differently to Ben. Ben runs differently to anybody else. And so this is the absolute jigsaw puzzle that we have to put together as clinicians. We have to try to figure out what we think is going to work best for a particular athlete. There is no such thing as footwear prescription. You cannot prescribe a shoe. You can only make a recommendation with your best knowledge and your best effort. But you can't prescribe, because that indicates that there is a dose perspective to athletic footwear, which there is not. So I don't think they're for everyone. And I don't think people should generally be training in these shoes. I think they're a race day shoe, but they're all different. Every brand is slightly different to the other, and there is no magic bullet. And some people have found that these shoes just don't work for them. So just exercise some caution in that regard. Okay, that's it. Thank you once again for listening. I'm appreciating it's getting a bit late there in the USA. So thank you for listening. And again, give us a follow, or if anybody wants to contact me anytime, I'm very happy to talk to you at any moment. So thanks, Ben. Over to you.
All right. So from one guy that's talking about anatomic contours to another, Golden Harper, he's always been looking at the width in the forefoot, and kind of grew up as a child prodigy marathon runner and in his parents' running shoe store. So Golden, you're going to wrap it up, and then Simon, stick around if you have a moment. We'll have a quick rundown at the end for just a quick panel. Golden, are you out there?
I am. Can you hear me?
Yes, sir.
Right on. Okay. You guys couldn't see me.
I recognize that room.
It was dark. Yeah, I'll bet you do. All right. Well, that was excellent. Fun stuff to talk about for sure. And yeah, just to introduce me to you guys. Let me see if I can share my screen here.
The designer of Ultra shoes, or I guess one of the main forces behind it. I don't know how many other people were involved with that, but you're kind of the
pretty much just me in the beginning.
Yep.
And as far as designing the shoes and whatnot, I no longer work for Ultra. So I've left there about a year and a half ago, and starting a new company, PR Gear, which we may or may not talk about here. But yeah, so there's my conflict of interest, I guess. But just a little bit about me real quick. I've been running since I was very young. My parents say I ran before I walked. My dad was working for Nike when I was born. He worked for Saucony most of my childhood. When I was 9, we opened a running shoe store, and I had begged to run my first marathon the year before that, which my parents did not allow. But working at the shoe store, running, and they did let me run my first marathon at age 10. So here's a picture of that, which is kind of hilarious and seems like a different lifetime to me. But needless to say, I've been running very far for a very long time. And almost the entirety of that time, I've been either working in a shoe store or working for a shoe company, or both, and have been influenced by the footwear industry, frankly, since I was born. So I am not a, I feel like there's a lot of really smart people here, and I'm a pseudo academic among you. But Ben asked me to talk about surface selection and shoes, and I find all the stuff that Simon was discussing, it's always fascinating. It's fun to stay on top of, and I agree, Simon, with what you were saying there at the end, which was essentially that people shouldn't be training in these shoes. And I know we don't have like great studies so far, but anecdotally, I hang out in a lot of elite and sub-elite runner circles, and know a lot of other people that do as well. And the people who are training in these shoes are getting messed up pretty bad on a regular basis from everything that we can tell. So I find that interesting. Part of that too is these, in my opinion, these shoes with their high mass can be really difficult to use on uneven terrain. And that's going to be some of the focus of what I'd like to talk about. So without further ado, let's jump into that. So running surfaces are something I'm super passionate about, something I believe a lot in, and something I studied extensively in my university studies. And when I'm speaking to a group, one of the things I'll admit is there's just not enough research on this. I wish we had more. And when it comes to all this stuff, it's really important that we get people to change slowly, and that's easier said than done, as you all know. But I always tell people, if everything's great, it's not a great time to change. If what you're doing is working, stick with it. If you're looking for improvement though, or you're injured, that might be a good time to make some of these changes. And I think this applies to surfaces, your running form, and shoes as well. And so I always tell people, people will say, oh, um, what should I do with my shoes or my form or whatever? And I'm like, well, come see me when you get hurt or you plateau or you need to improve. That's a better time to talk about that. So I do think that slowly phasing in more natural surfaces, shoes, and form is playing the long game, and it's better in the long run. And in Simon's first session, he mentioned the footballers or soccer players going from wearing traditional shoes with a 3/4 inch lift, which is a lot, to wearing soccer boots, doing a really high impact activity in a shoe that is not only has no drop, but they also typically have a really tight toe box, which as most of you know, essentially renders the arch useless. The foot loses so much control in that situation, and I think that change is ill-advised. So I don't necessarily disagree. I think if people would make that change slowly to a shoe with no drop, they would be fine. But also, like, you need the width in the toe box. The first ray has to straighten out, and that combination of both no drop and straight big toe is a critical thing to have happen together, in my opinion. So, and essentially what I'm talking about is this kind of reduced dependency on unnatural, whatever it happens to be, a heel lift, an orthotic, overly supportive shoes, you name it. Getting people to slowly phase out support while slowly phasing in strengthening and more natural positioning as the feet become stronger and more dynamic and assume their more natural position, then the need for support is obviously reduced. And we see this play out to beautiful effect all the time on a regular basis. And in my opinion, this is the way to do things. And this curve could last a few weeks in some circumstances. It could last, 6 months to a year in more extreme circumstances. For example, at my shoe store, we studied the effects of Five Fingers when they first came out, Vibram Five Fingers, the barefoot style running shoes. And we found that people took an entire year to transition from traditional raised heel tapered toe box running shoes to a barefoot style shoe with no cushioning. That was the timeline for the average athlete that was coming into our shoe store, was a year. So that curve, can take varying amounts of time. And that's important consideration as well. Okay, on to surfaces. This is the thing I always ask, and I talk to if I'm speaking to a big group. I always tell them, if you have to choose between the road and the sidewalk, which do you choose and why? And everybody always yells out the road, and I'm like, why? And they're always like, oh, because it's softer. And I once had a concrete and asphalt engineer in one of these clinics, and he's like, yeah, guys, they're both crushed rocks. The hardness differential between those is 0.6%. You wouldn't want to hit your head on either of them, and frankly, it doesn't really make that much of a difference. So, I think another point along these lines is what happened to joint injury rates when cushioned treadmill decks were created. Because if y'all remember, the marketing was, oh, treadmills are soft now, injuries are going to go away. Treadmills used to be rock hard, and now they've got cushioned decks, and now you can run and not get injured. And as far as we can tell, as far as I've been able to find from all the research, the amount of injuries did not change at all. It might have changed where the injuries were occurring a little bit, but the amount did not. And the reason is leg stiffness, and we can come back to that here in just a second. So this is kind of a discussion of hard versus soft, and I like to tell people it's kind of a mixed bag, and it doesn't matter a whole lot. And a lot of that is due to muscle tuning. We impact harder on softer surfaces, and our bodies land softer on firmer surfaces. And if you need a mental picture for this, just imagine yourself running barefoot on the beach. You run off of the soft sand and onto the sidewalk, and what happens? Your body immediately goes to bending your knees more, taking quicker, softer, lighter steps, etc. So because of muscle tuning, your body basically pre-tunes, what it thinks the surface is going to be, and it lands softer or harder based on what the surface is. So the hard versus soft treadmill doesn't seem to have a huge effect. There's conflicting research here a little bit in some ways. Ben O'Nig, he's shown that higher impact loading rates can equate to lower injury risk as overall. And Irene Davis has actually linked high impact loading rates, so vertical loading rates, specifically with plantar fasciosis and tibial stress fractures. So I don't know that it's necessarily a matter of which one is better overall, but more a matter of which one is better for which injury. And so there's some practical application here. Based on what we have just talked about, we need to keep in mind that leg stiffness is less while running on a hard surface. The knee bends more, and it's more when running on a soft surface. There's a typo there. So the knee bends less on a softer surface. So, one takeaway here is if your patient has a history of plantar fasciosis, any sort of plantar fascia issues or tibial stress fractures, you might want to consider switching them to a thinner, firmer shoe to keep impact loading rates down. On the other hand, if they've had a lot of muscle and tendon injuries, you might consider recommending as much grass and trail as is practical to help out on that side of things. So here's another one we're not like totally sure about, but this is another one I tend to ask groups, and what two surfaces cause the most injuries. And I'm talking chronic running injuries, not acute injuries. And as best as I can tell, they both start with T. So they are both soft as well. They're your tracks and your treadmills. And I think people are like, oh, whoa, but they're soft. Soft surfaces are better. And are they? Maybe it has nothing to do with the soft. Maybe these could both be hard and it wouldn't change. So why is it that we're seeing so many injuries on these soft or cushioned surfaces? And I was asking this question, back in college 20 plus years ago, and I believe it's because every step is exactly the same, and humans aren't built to do that. And this kind of brings me to my main thesis here, is that most chronic running injuries likely come from muscle imbalances caused by every step being the same. So, we can call them overuse injuries, we can call them repetitive stress injuries, we can call them what we want. But in my opinion, most chronic running injuries likely come from muscle imbalances caused by every step being the same. And a lot of that is because humans are not built to do that. Most of you probably studied anatomy. Most of you probably know a lot about the musculoskeletal system, and you know that our bodies were designed for variability. For eons, humans have been ambulating over uneven terrain. It's what our muscle structure is built to do. It's the way our foot is built to work as well. To me, this is just a huge thing to think about how humans have always moved for all of human history until really less, about the last 100 years or less in most places. So we've had a dramatic shift in the type of surface that humans are existing on. And in my opinion, our bodies were not prepared to make this shift that quickly. And so we did a big research survey and study in college, and we found that trail runners were 2 times less injured than road runners, twice. And despite, we asked their running habits and stuff, they're running on average 2 times more time than the average road runner that we surveyed. This was several hundred. And so you might say per mile, they were 4 times less injured per mile. I thought that was really interesting. And so we decided to do several hundred more and look at people who did both. And what we found was that runners who ran 1/3 of their miles, or about 1 out of 3 miles, on uneven ground of some sort, gravel, dirt, grass, trail, you name it, that produced a significant decrease in injury rate. It actually, those people were similar in their injury rates, not quite as good, but pretty close to full-time trail runners. So you don't have to run trail full time to get this effect. But the magic number, we saw a huge crossover where there wasn't a massive effect at 1 out of 4 miles, but when we got to 1 out of 3 miles, there seemed to be a really big protective effect there. So I always jokingly tell people, hey, step in potholes, duck under trees, make an effort to make your hips tilt, step up on curbs, run trail whenever possible, run on your neighbor's lawns, take laps on the grass at the local park. Use your eyes. You can find uneven ground anywhere you want. I don't care if you live in the middle of the big city. There are ways to find uneven ground. Don't jump from being a full-time road runner to a full-time trail runner immediately. Back to our first discussion point, phase over slowly. And I think you can see some big success. So building on this, I think you see a lot of people promote strength training for non-running muscles. And I think that is, there's some decent research there, and it can be effective. It's essentially having a similar effect. I think being a little bit more practical in actually doing the activity, meaning running on uneven ground, is probably more effective. But I think the next thing is, again, humans are not built to go on perfectly flat, even ground, and we're not built to go straight linear all the time. And so if we can get people to do something active besides running, that's a huge deal from a surface standpoint. So and sitting on the shoe bench as a kid, I remember my dad used to tell people, like, hey, if you get these 2 different types of shoes, you're going to be less injured by like 20+%. And I'd always sit there like, bull crap, and it turns out, there's been multiple studies on this over the years. The most recent is a Malisu study, and in 2015, and he found that there was a 39% lower injury risk just by wearing different types of shoes. So this could mean, high cushion, low cushion, trail shoe, road shoe. It doesn't really matter. Different types of shoes, one brand, another brand, low drop shoe, high drop shoe, stability shoe, neutral shoe, whatever, just different types of shoes. So if shoes can produce that much of a lower injury risk, imagine what changing up your surface could do. Other studies have shown that you have a 25% lower injury risk by participating in any other sport. And I would love to run this study with nonlinear sports. Basically take biking and swimming out of the occasion and make it be pickleball, tennis, basketball, anything that has more of a side-to-side component. And I'll bet this number goes to 90% plus. You reduce injuries just absolutely drastically by getting people to do a non-linear sport, get them moving side to side. And along these lines, we've pretty good studies showing that only 5% of those who do hip strengthening, which is kind of what these things do, have any injury reoccurrence, and they tend to be really successful. So, pretty cool stuff. Okay, so the take home there is, hey, let's slowly phase people over to getting 1/3 of their mileage on uneven ground, dirt, grass, cobblestones, whatever. It doesn't, hard or soft doesn't seem to matter a whole lot. And we'll kind of dig into the weeds here a little bit on that, but there's not a ton here. So a treadmill, you're going to use less hamstrings, you're going to use more quads. Treadmill is going to absorb shock at a rate of 71% compared to none on the asphalt. But that comes at a cost to the Achilles, is what we see from some studies. And on the flip side, people tend to have a slightly higher cadence and less rear foot strike on the treadmill by just a little bit in both cases. And one study found you'll experience lower bone strains on the tibia when running on treadmills. So treadmills maybe not so great for the Achilles, a little easier on the tibia. So grass, this should be pretty obvious. Grass, it's soft, it's variable, it reduces total stress on the body as a whole. Again, the trade-off, as Simon said, force doesn't magically disappear, it has to go somewhere. So you're going to increase that stress on the ankle area. And again, I'm going to argue that that ankle area is adaptable over time. So that's a good place to slowly phase more stress onto, because it will get used to it and get stronger and be able to handle that. So a couple general considerations when it comes to surface. Ankle mobility is likely the most important thing we can do in preventing injuries, just because we have constant inversion, eversion happening with running, slight grades, berms on the road, etc. So that's going to directly affect the knees and hips. And then, we're going to see more PF and more tibial stress fractures in road runners. One thing I think is really interesting, you read any of Toby Tanzer's books about living and running with the Kenyans. And these guys are doing enormous amount of miles, running dirt almost exclusively. Their injury rates in general are far lower than most of Americans and developed world runners. So I think that's fascinating, and obviously have become a big believer in that over the years as well. And then what's interesting here is males experience 89% of all Achilles tendon injuries. So that's a huge number, and about half of runners are going to experience Achilles during their career. So I think the kind of trade-off here for most runners, they're dealing with knee, shin, IT band, plantar fascia, foot arch injuries. Those are our big injuries that we see. On the flip side, your elite and high mileage runners, their most common running injury site is actually the Achilles. So given that treadmills, tracks, grass, etc., are associated with higher strain on the Achilles, it might be prudent to recommend firm dirt trails, crushed gravel paths, etc., roads to alleviate potential injury in high mileage runners, specifically elite athletes, may be better off in those situations as far as for the bulk of their mileage. And I think that's an interesting consideration that I don't hear a lot of people talk about. So, and when I developed Ultra initially with foot shaped zero drop shoes, the target for those was beginning runners, recreational runners, people who are dealing with knee, shin, IT band, plantar fascia injuries. And I think over the last 10 to 15 years, I feel like it's been very effective with those people. And I've never been one to be recommending high mileage elite runners switch over to ultras or other zero drop shoes quickly. They can use it as a tool, they can transition slowly, but they may not get the same benefit because they're also not typically overstriding at the same rate as most are. So shoe selection considerations real quick, just a few things. How to fit. I'm a big believer you got to let the comfort do the talking at our shoe store. So my family still owns the shoe store. I still go work there and sell shoes occasionally. We find we're really successful when we let the comfort do the talking and we do not program the individual or the customer at all. We try and give them as little information about the shoe as possible and let them make the decision based on what shoe feels great while running in it. And I'll come back to that in a second. But fit is really hard to get people right. Most people buy their shoes, way too short. And so getting them to get that thumbnail's width between their longest toe and the end of the shoe is a fight, but it's critical. We feel like we see much better outcomes when people get their shoes big enough. We want the shoe to feel uncomfortably loose in the toes at first, basically. And I always tell people it has to be oversold. and people are used to having their toes squeezed by shoes. You know, if you want your toes to get in the game, help support your arch, attenuate shock, you want them to spread out as much as possible. So if they don't feel too big in the toes, they're too small. That's the thing we'll always tell people with shoes. If your shoes don't feel too big in the toes at first, they are too small. It takes people a minute to get there. So another thing with shoe fitting, I'm a really big believer we need to meet people with where they're at. So change only one variable at a time, basically. So the bulk of people I meet with are recreational runners who are dealing with some sort of joint injury or PF. And so for me, I'm going to adjust their platform. I'm going to adjust their running form to get them to be overstriding less. I'm going to get them on a variable surface, like a trail, for a third of their mileage. And with their shoe, most of them, I'm going to get them in something that's going to help them run more naturally. So I'm going to change their platform, meaning I'm going to get their toes to spread and I'm going to get their heel down. And but I want to keep their cushion level the same or even a little more than they're used to, because we have changed a variable. And to me, it's really important we only change one variable at a time. So obviously, that's the bulk of the people I work with. I work with others where we'll make obviously very different changes than that. But something I think is a really important takeaway is what people are wearing all day, every day is likely more important than what they're running in when it comes to their foot pain, the control they're getting, their foot strength, etc. I'm less concerned about what they're running in. I'm more concerned in what they're spending 12 hours of the day in. You know, I find that those who tend to wear more supportive shoes, orthotics, higher heels, tighter toe boxes for their all day, everyday shoes tend to have the most problems across the board. And I'll come back to why in just a little bit. So so in summary, it's kind of a battle to get people to get their shoes loose enough and big enough. People just like control. They like things to be tight. They tie their laces too tight. You really should be able to get a finger underneath the laces. Blood flow is really important for all parts of the body and especially the feet. So we want it to be happening and we don't want it cut off. You know, even just raising the heel a half inch, that's going to tighten the retinaculum back there over that main supply artery to the foot, underneath the medial malleolus. So, you know, anything we can do to get more blood flow, I think is always good. So shoe companies design this length in the shoes. So, you know, they have to deal with tons of different foot types. So having that length in the shoe is pretty critical to get the shoe to be fitting where it was designed to be fit in the first place. And another interesting thing that I think a lot of people don't think about is I use correct toes as let's see if I can stop the screen share here for a second. I use these as a shoe fitting device. So I just have them put them in and I say, you know, go put the shoe on. And if the shoe's comfortable with these in, then it's letting your foot do its thing the way it's supposed to when it hits the ground. It's able to attenuate shock, and then get the mid stance and then do propulsion effectively. And more than anything, you know, just comfort. So comfort's really important when it comes to buying shoes. And I find if we can get people to fit their shoes while wearing correct toes, then they're going to be a lot more comfortable. So, and they're going to have a lot more success. So, okay, so a few more building from there. Where are we? Here we go. So again, go back to just change one variable. Okay, so another thing is like so many people buy running shoes without running on them. They judge the shoe how it feels walking or standing, and I think that is just unintelligent. We see far better outcomes when we get people to judge the shoe by how it feels while running and only running. Now, if they're buying the shoe for walking, while walking and only walking, how the shoe feels standing for a running shoe is fairly irrelevant. We at our shoe store, we have people actually go run outside on the shoes, and they run with one model on one foot and a different model on the other foot. And once we get down to final 2 or 3 pair, then they'll go full pairs from there. It's usually pretty obvious to people pretty quick though. And we instruct them to not judge the shoe until they're actually running on it on the surface that they run on. So if they're primarily a treadmill runner, we'll put them on the treadmill. If they're primarily an outside runner, we'll put them outside and have them judge the shoes while running on the surface that they run on. You know, there's a lot of research on the comfort filter, and I'm a believer. I just don't know that a lot of patients or customers know what comfort is. And you know, our anecdotal evidence over 30 years now tells us that selecting shoes by comfort is far more effective than by assigning a category or by what we think is best. So, for example, we got a treadmill gait analysis system and started doing the whole video from behind pronation thing, and then assigning shoes based on that, and then having them run on them and pick shoes there. And over the course of a couple of years, we saw our reported injury rate of our customers go up by over double, and our return rate go up by over double as well. And that's when we pulled the treadmill and pulled the rear foot gait analysis, and went back to a focus on comfort, and watched both of those numbers drop back down to where they were before. So these are big things. Ben, have I got like 7 minutes left? Am I reading that right?
Can we wrap it in 3 to get us before 8, and then if we have a couple minutes for questions?
I'll see what I can do. Okay. Okay.
Or
So
3 to 5. Go ahead.
Okay. Yeah. Another big one here is 2015 meta-analysis or a systematic review found pretty strong evidence that having used orthotics or inserts was associated with an increased risk of running injuries. And that's an interesting one to think about. I think it could make sense for a lot of us for various reasons. Those that wear orthotics or inserts generally have had a history of running, which we already know is associated with increased risk of running injuries. There's probably various reasons. They're probably compromised to start with. I'll go as far as saying they likely have weaker feet or more deformed feet in most situations, or more genetic anomalies they're dealing with. So, I like to try and get people to a more natural place. So just kind of blowing through some of the myths that we deal with when fitting people with shoes. Most people buying running shoes think that modern running shoes are going to reduce injuries. That's just not true. We haven't seen that. Running injuries have gone up or been flat at best since modern running shoes have been invented. So shoes don't seem to be good at reducing injuries. And along these lines, I think part of it is the way people move has changed dramatically. Go watch any old movie prior to the 1960s, prior to elevated heel running shoes, and the way people walk and run is different than it is now. People move fundamentally differently than they did prior to the invention of modern shoes. And so I'm a big proponent of not necessarily switching everybody's shoes right away, but giving everyone a quick form lesson. Less than 2% of distance runners have had any formal distance running technique training. That's insane. We would never do that in any other sport. If we did it in swimming, we'd have dead people. And it's fairly easy to counter. We just keep the elbows behind the hips. You are all aware of crosstalk principle of biomechanics. My new company, we're developing a thing here called the float run harness. And these are going to be out in a couple months, but essentially it's a rubber band strap that you just put on like a jacket or a t-shirt, and it's got these thumb loops in it, and it keeps your elbows back, and it doesn't let your elbow come forward past your hips, basically, or reminds you not to. So it keeps you in that powerful elbows back position that you see most of the elite runners run in, and that's going to keep the overstriding from happening because you're because of crosstalk principle there. So I find it to be very, very effective. So just instructing people to keep their elbows back and not let their elbow come forward past their hip is just huge. So next, cushioning doesn't work the way people think. Many of you know this, but people think cushioning will save your joints. It's just not true. So when it comes to shoes, I tell people, this is oversimplifying and we can get into nuances, but we don't have time. But cushioning doesn't protect your joints. It does take pressure off the foot and lower leg area, so Achilles, soleus, etc. So if I have somebody with issues down there, I'm going to put them in a more cushioned shoe. If I have somebody with issues more up at their joint level, I'm going to get them into a more natural shoe, more flexible shoe, or less cushioned shoe, and have them work on their running technique. Those are really the big considerations. So lower drop shoes for knee and joint issues, more cushioned shoes for for things like Achilles or arches or whatever. So let's see. Okay. Next, traditional running shoes are going to help people run better. Again, it's just not true. The reality is actually the opposite. So we've seen that the advent of the traditional running shoe, people run worse. They tend to overstride more. They move less naturally. They produce more force across the board at the joint level, especially. So next, good supportive modern shoes will prevent or cure foot problems. And, this is going back to what I was talking about earlier. 73% of Americans report foot pain annually. That's huge. With the, near billion people on the planet that still go barefoot or wear primitive sandals, that number is 3%, and it's almost all acute injuries. It's not, the bunions, neuromas, plantar fasciosis, hammer-toes, etc., stuff we see with most people in the modern world. So, getting people into a more natural shoe for their all day, every day, again, to me is just like super critical. Love showing this slide, but natural feet and toes before wearing modern shoes, feet and toes after wearing modern shoes. So when your feet are weak or deformed out of their natural shape, they're not going to stabilize well. They're not going to control landing well. And I always just try to make a point with people, like, your feet are your landing gear, and you really want to build your landing gear. That's super important. So, we can go through this stuff, but I just want to get to one last thing. Simon harps on this a lot too. Pronation is just not the thing that running stores, they sell shoes based on pronation, and it's a huge mistake. We really shouldn't be doing this. I see this all the time. So common to see people with these stability running shoes. This is a Brooks Adrenaline with the wear on the lateral side. And it brings us to what I believe is the strongest injury prevention thing out there when it comes to shoes. Stronger feet are less injury prone. They don't need as much support. They often don't need insoles or orthotics at nearly a rate as weaker feet. They provide the better body with better stability, impact absorption control. We've had really cool studies the last 3 years done on this. Doing foot strengthening makes the athlete as much as 2.42 times less likely to be injured. That is just massive, people. It's the biggest thing we have for reducing injuries in runners by far that I've come across. So we just need to get people actually building their landing gear. You are landing on these things, thousands of times every single run. And so, and it's as simple as getting people to walk barefoot for 30 seconds and add 30 seconds every few days. Then start doing this with running. Take off your shoes whenever possible, as long as it's comfortable, preferably on softer surfaces. And we have studies showing that people just walking around in barefoot style shoes or walking around barefoot got the same foot strengthening effects as those doing exercises. So this is makes it super easy to recommend to people. You don't have to give them a whole slew of exercises like balancing on one foot, which I think is awesome and really effective, like pulling in a towel with your toes or jumping rope without shoes or any of these. There's a million foot strengthening exercises out there. We get similar outcomes just by having people live their life in barefoot style shoes or without shoes on. So there's a ton of cool research I'd love to go through here. Don't have time. Let's I always like to just kind of choose the outline that matches your feet when it comes to selecting a shoe. I don't think it's that complicated. It's I always thought this was crazy, but this is a 4E Brooks Adrenaline on the right side. Good shoe for a lot of people in a lot of different ways, but just illustrating the point that wide and being shaped like feet are very different things. Yep, teach technique. And with that said, thanks a lot. There's there's a lot we could go through. So thanks for having me, Ben.
Well,
Love to take any questions after.
This was great,
Stop the share
and
here.
leave it to you to finish strong in the marathon biomechanics session in the home stretch. Does anybody have any questions? I haven't looked. I see 4 new messages. Anybody want to ask any specific questions to any of the speakers that hopefully are still here? I've got one to lead off, and I like those intrinsic exercises. Do you have any ones that you like? And I'm gonna also position this to you, Simon. Rich taught me about neural flossing, which I didn't know about, but I have a neuroma, and I've got to actually get a better solution for my soccer cleat. I've got an Adidas soccer cleat, and the follow-up question was going to be to Simon, why haven't we seen better? It just seems like running shoes have such great design. For me, soccer boots stink, especially on turf. And I constantly aggravate my neuroma. There's just a lot of cutting. I'm 57 years old, and I'm trying to hang out with, dance with 27-year-olds, playing defense and such. So I need to do a little bit more orthotic control in those, and maybe it's just that the cleats are bending. There's a lot of torque on them, and I need to replace them more frequently. But I first wanted to, I know neural flossing was a technique that's used for splaying the toes. Any other specific ones you have, Golden, for neuromas that you like to do? And of course, using correct toe. I would never use a correct toe in a soccer cleat, though. It'd kill me.
That's because the soccer cleats suck.
Yeah.
Shape wise, and I don't know what you can do about that realistically. I mean, at the end of the day, it's pretty simple. Your foot's supposed to be like this. It comes like this. You're born like this, and then you put it in a soccer cleat that does this and impinges all the nerves. Of course
you're on turf, and you're hitting the door, the turf, and you're hitting the ball, and then sometimes you get your foot stomped on. Any ideas why we haven't seen better soccer cleat design, Simon? I know you've got some specialty shoes.
Yeah.
They seem super cheap.
Yeah. Look, I think of any category you can think of any footwear in the world, soccer cleats are the most derelict of any design. And the reason this is that it's a unique situation where the design of soccer cleats is 100% dictated by the athlete. So in other words, the athlete has a perception of what a soccer cleat should look like. So it should enclose their foot very tightly so they feel and caress the ball, which is all complete nonsense. It must not have any sort of meaningful midsole because it removes you from the pitch too much. So nothing at all to help, with the load. These guys are running, somewhere between 13 and 15 kilometers every game they play. So if you imagine going out and running 13 or 15 kilometers in a soccer cleat, that will give you some idea. So the sport and the shoe is absolutely ripe for disruptive, radical change. But there's massive resistance from within the community because a soccer cleat has to look a particular way and it has to fit a particular way. And none of that is based on any science at all, unfortunately. So as you can tell, I get a bit steamed up about this because I've worked with football boots for so many years, and I'd love to see change, but it's like pulling teeth with the community. They have no desire to see change. We're running is a much more fluid community. They embrace different ideas and different concepts and different trends, and they'll give it a go. And it's like it's like the old hype cycle. You get to a certain point. Does it fulfill the hype? If it does, then it will continue. If it doesn't, well, then it will just fade away. So this is the issue we have with soccer, and I honestly, it's one of the things that keeps me awake at night. I don't know how to solve the problem, but it sure needs solving.
Rich, any ideas on neural flossing and how long you would expect that to help with that extension and flexion of the toes that you have in book 2, a little diagram? Any other things over the years for, you can do the intrinsic exercises that we all advocate, the splay toes, the short flexor arch, the yoga toes or piano toes, as I like to call it. But at the end of the day, any other things that you like to do with neuromas?
The classic stuff besides neuroflossing is a lot of foot massage. A lot
I do that.
foot mobility stuff because you want to untrap those nerves. I'll send people to physical therapy for 4 or 5 sessions, but usually they can learn it, or they force their husband or their wives to do it to try to get. And I actually encourage, like, go have your husband or wife go to therapy with you to, like, there's some general rules that you should do and shouldn't do. Of course, a metatarsal arch, I think, is crucial to get it behind the metatarsals. All right, Golden. Very nice to meet you, too. I do have to confess, Golden, that some of my runners who want to get out of their orthotics into ultras, as they're transitioning, I can't tell any of their other running community that they're wearing their orthotics in the ultras until they're fully weaned out. So, but a little funny story.
Well, that's back to my only change one variable. I'm a huge believer in that. Like, if you're going to change the shoe, you better keep that orthotic in there at first.
Yeah,
for sure. So I'm with you. I totally know the struggle though, because the community's passionate.
Yeah. So metatarsal doming is so when you're dealing with neuromas, I like the doming or arcing and bend instead of
across the transverse arch you're talking then.
Yeah.
Instead of
picking up towels and
stuff
like that. I like single leg balancing. I think the big thing that I would say about just relying on exercise, Golden, I'm sorry, is we see all these imbalances, where the perineals are so much weaker than the posterior tib. And we've got to be, at least for a while, very direct at trying to correct those imbalances, where it doesn't seem, even though they're trying to, do it all naturally and doing functional exercises or doing, just doing their running, I can't seem to get that imbalance corrected unless they're just strengthening their perineals for a while, or their posterior tib on the inverter side, or their Achilles. I see so many people who've had Achilles problems who come in and they're so over flexible. They're like, our gold standard is they can bend their ankle 10 degrees and that's normal. They come in and they're 30 degrees bent and they have no power in their Achilles at all. So we've got to get them, a more, direct strengthening program. And hopefully within 3 or 4 months, they can reverse those imbalances.
I agree with that. Absolutely. Yep.
Anyway,
I think the whole area of exercise medicine is in its infancy, and certainly with things like Achilles tendinopathy, it's a matter of actually increasing tissue load tolerance over a period of time. So with Achilles tendinopathy particularly, I use a very progressive program over a period of time where you are basically trying to get them to a point where they can do explosive plyometrics at the end. That's the end desire. Yeah. And it's very, very effective, and it's very supported by the research. So, the whole concept where we were looking at fairly static treatment methods with, perhaps an orthotic device or maybe some stretching and some calf raises and stuff like that. That's not what it's about at all. It's really trying to understand what caused the injury in the first case. So this whole concept of how do you assess your patient? Do you look at their dynamic function, or have you just got them on the table and you're looking at their range of motion testing? Because it's a combination of both, but just looking at range of motion testing won't cut it. You've got to actually try to understand what was the environment that caused the injury. And then you have to try to understand how you're going to reproduce that over a period of time to strengthen it. And that's the whole concept of exercise prescription for specific injury. And it's different for every individual. There's no cookie cutter approach to it, and it's different for every injury, basically. But as a part of a treatment program, it's super effective.
Well said. Really well said. Hey, Ben, I was just thinking on your soccer cleat issue. I had two thoughts. I would go try on 15 different pairs of soccer cleats while you're wearing correct toes. And the pair that where it feels the most comfortable is probably going to be the best for your neuroma. And second thought is I'll have to get you a pair of these. I've developed these bridge soles. And these are meant to offload the foot and lower leg. And essentially it's a full PEDAG style met pad, a transverse arch, and a deep soft heel cup. And you would basically take the insole out of your soccer cleats. You put this in instead. It's only 3/4 length, so your toes are going to be more free. They're going to be able to spread out more, but you're also going to have that met pad in there. And it's a full 7 mil thick met pad, so really similar to a PEDAG. And maybe that combination of
Great idea. And
those two things could help.
Another thing I was thinking is you're always playing in the rain, and then the leather shrinks up, and the notoriously tight soccer cleat that's already too tight gets even tighter after that.
So
Mike,
probably shoe stretchers after they get wet.
Yep.
So they aren't able to shrink down.
Mike, do you want to let everybody know when the Academy meeting is next or coming up? Are you Mike Donato? Are you still here, Mike? There's going to be an Academy sports medicine meeting in DC next year. And I'm looking for, it's my hometown, so I'll be there. But I'm looking forward to going to that.
All right. Sorry about that. I couldn't get through. Can you hear me now?
Yeah.
Yes.
Yeah. When is that,
So
Mike?
it's, the 13th through the 15th at the Marriott downtown in DC. And we have a lot of good speakers coming. We have a local flavor with some people from the Marine Corps Marathon. We got a lecture on adaptive athletes, which we haven't seen at our lectures before. We got some really good people that'll be there. We got ultrasound workshops. We've got we'll have still Nick Mafuli, Corin Hudson, who works with the Capitals, and she'll give us a concussion overview. So we just have a lot of really good people. We're really excited. Me and Jay are actually going there on Saturday to the hotel to scope it out so we can try to get a good idea of the layout. We felt in Seattle, maybe we ran around too much at the hotel. So hopefully now we can find something that'll, we can keep all the workshops close by. And also we're going to try to have a little bit more fun this year, a little bit more social, which will be a lot of fun too.
Good. And one of the other things that happens at these meetings.
So Ben,
yep, go ahead.
So hey Ben, so this is what a soccer cleat should look like.
I like it. That's the multimodal.
So this is a shoe. This is a shoe I developed for a company called Osaka for field hockey. But you can see the language that we're talking about here. So rather than just having a couple of cleats, you're talking about directional changes. And you can see that these are all the cleats have actually got completely different directional changes. It's got a special setup here for the cuboid. It's decoupled, so you've got different platforms. It has rounded bulbous contouring so that you're always going to have some shoe on the surface. And this is really sort of a bit of a blueprint for what a football boot should actually look like, rather than just the really traditional horrible design we've got now. We actually designed this shoe for the Belgian Olympic team, and they duly went out and won the gold medal by beating Australia in the gold medal round in the Olympic Games. So we did too good a job with that one. But that's the sort of disruption that needs to come to football.
Absolutely. It's segmented like the foot. I love it. And very, very anatomic. The last thing that Mike was just mentioning, workshops, and to the bit about exercise medicine and just doing certain exercises. I think one of the other things we pick up at these meetings is that there are sometimes nuances whereby I was working with Ted a little bit. We were doing hip hikes and things, and I found I've got some glute weakness, and it wasn't detected because by myself. But then I was kind of coached through it that I was compensating with my ITB. So that's one of the things that I love about the meetings where you're in these breakout workshop that you know, Jay and everybody else that had anything to do with that track did a nice job of putting together, and they were really good. So I hope we have some more hands-on like that, Mike, because that was really effective.
Yeah, we definitely do. It's going to be a lot of fun. I think, you know, we're going to make it fun, and we have a lot of good people coming again.
Well, I want to thank all our speakers tonight for participating and hanging in there to the bitter end. And you know, I'm going to do this in 24 again. Some of the folks will hopefully recycle, and then I'll take any ideas that we have for new topics. Maybe get a little bit on tissue strain theory. Look at some of the electrophysics of muscle interaction. I'm kind of getting interested in electromagnetics, but you know, we'll continue this, and hopefully it'll be something that we can grow. And I love the community that can talk to each other and exchange ideas.
Well, thanks for putting it together. We really appreciate it.
Yeah, thanks,
Yeah,
Ben.
thanks, Ben.
Good night, everybody. See you in
Good night.
24.
Night.
Hopefully
Thanks a
before.
lot.
Bye.
Thanks,
Bye.
guys.
Appreciate it.